And this time is the theme is glioma and functional neurosurgery, because Dr. Ibrahim, he asked us to have this theme. And me and Dr. Adi from Bosnia and Herzegovina will be the MC today. So I think at the beginning, just thank you very much for senior professor from 4 countries. So can I see the Dr. Ibrahim face? Ibrahim? So that we are so happy. Hi, Ibrahim, how are you?
Thank you. Good morning, everybody, especially to you, Professor Kato, and all other colleagues who are enjoying with us today. Good morning. Actually, in Bosnia is morning, yes, and in Japan is afternoon.
Japan is 3 p.m. Anyway, so the Bosnia Herzegovina and the Kosovo and Albania, and also the Macedonia.
Yes, the same time, yes, same time zone.
Okay. So maybe Ibrahim, you want to say something, please?
Just to say hello to all of you. I'm happy to see you again, all here. This is second meeting together with Bosnia and ASEAN Congress of Neurosurgery, especially with the colleagues from Japan and China and other countries. Also, this time we are trying, and I see that we succeed with sharing this story with colleagues from region, especially with the people from Albania, my friends, my dear friends, Professor Petrella and Ali Mehmeti, who have been our guests in Sarajevo a few times in our meetings. Also, my friend Arion from Canada, which is also originally from Albania, Professor Morina from Kosovo, and also I'm happy to see some new professors from China and Japan. I have never met them before, so this is good opportunity also to meet, to share our company in these meetings. So I hope and I believe this meeting today will be useful for all of us, and we will learn something and have the chance to share our knowledge and our dilemmas together, and also to share our recommendations to young people who are watching this webinar today. Thank you.
Thank you very much. So I want to share some of my several slides. So today, I want to show several introduction of the Asian Congress. So today's webinar already Ibrahim, he mentioned about the theme is a glioma and functional neurosurgery. It's a very difficult field for the young doctors, but I think it's a very important region to learn. So Asian Congress is established in 1993. And late Persacano, he passed away last year, in August, unfortunately. So he is founding the president, then an emeritus professor of the Fujita Health University. So everybody knows is Persacano is understanding of the patient and the neurosurgeon as human beings, in spite of all the complexities of our world. He is really a high humanity person. So we learned a lot from him, how to treat the patients, how to side by side, we should work with the patient. So this picture is quite old. This was taken 1993, the real first Asian Congress. At the time, we do not say ACNS, but Professor Kano, he invited 100 young neurosurgeons from not all over the world, mainly from the Asia. Maybe you can you can understand who is the Mishra and Dr. Eka, and also the guy from Vietnam, Hanoi, and Taiwan, and Pakistan, and so many countries. So we gathered, then we studied, was invited the guest speech. 1 week that we stayed together, kind of the dormitory of the Toyota motor car, the dormitory. So not only we had a good time having the lecture, but also the exchange, their culture, and many things. I think it's very important for the younger generation to know what happened in the neighbor countries. And also, Professor Kano focused on the nurses, not only for the doctors, but also he devoted to the nurses. She is from India, and she is a scrubbing nurse. So we work together. And also the 3 nurses come from Sri Lanka. They were so happy with advanced technical surgery. And this is our kind of we consist of the so many part of the ACNS educational committee led by Dr. Roger, and also the female section, and also honorary president section, and also the women neurosurgery led by Dr. Sharon, and so many doctors, and also YNS committee. So we exchange the knowledge and the skill, and also that we have a nurse session. So anytime I think we can invite your country's doctors, nurses, residents, the medical students, everybody. We can very happy to welcome. And this is every year we had the winter seminar. So he is a Professor Kano, late Professor Kano, and so many doctors. So this is a hands-on, endovascular hands-on. She is a society president of Mongolia, and the guy from Egypt. So the hands-on and lectures, and after that we went to the operation theater. The young doctors can join from the beginning to the end. So, and also they can have some chance to present their paper. And finally, we can give them some award, the 3 awards. So these activities, I think it's quite important for young doctors, young generation. So this is the WMS Foundation and also ACNS collaboration education course in Africa. So this is Zimbabwe. So Dr. Imad Cannon. So just he became president-elect of the WANS society. So Dr. Keketril and young doctors can present their papers, and they can bring their patient film, then discussed. So after that, we had a demonstrative surgery. So at that time, we did the tank surgery. And also we brought the Temporal microscope, the card size lens. So they were so happy to learn the skillful the surgical techniques. And finally, we discuss some cases. I'm sure you've seen. So during the COVID, times that we had so many webinars among the many categories. So Dr. Raja, that he conducted more than 200 ACNS webinars twice a week. So anyway, so this is how to achieve the education and training of the young neurosurgeon. This educational the books we published, and also CD or DVD or movies we can give the young doctors. And also we encourage the research, the publication. And sometimes we can donate some micro-instrument to the developing countries. So, and the big event is every 2 years. We have Asian Congress, ACNS at the Congress. So the next one will be Dr. Mao In, 2022, October 28 to 30 in Shanghai. So after that, it comes to the Egypt, Cairo, Professor Nazil. So it's already 14 times. So I think for young doctors, never give up. Please, you can polish the knowledge and the skills forever. So thank you for your attention. So this is just a brief introduction of the ACNS. So I think the next I want to ask Professor Alcim Molina, just say a few words.
Good morning again, or good afternoon to you in Asia. On behalf of our Neurosurgical Society of Kosovo, it's a great pleasure and honor to join you in this webinar with has challenging topics such as gliomas and functional neurosurgery with distinguished lecturer. Special thanks goes to moderator for invitation for you, Professor Kata, Yoko Kata, for giving me the opportunity to present you today shortly current situation in neurosurgery in newborn of Kosovo. I'm glad also to see today and my fellow neurosurgeons from region, Ibrahim, Arion, Mentor, Ridvan, and Blerim. Just a moment, slide, yes. Kosovo, yes. Kosovo has human resource are the greatest capital and assets. The 10 years of segregation, as you know, had a disastrous effect on education of these young people. Thankfully, at the end of the war in Kosovo in 1999, the medical and education system underwent important change and reforms. So I will try to present some general information about current situation of neurosurgery in Kosovo. Regarding infrastructure, our ward has 25 beds, semi-intensive care and central intensive care unit, 2 operation theaters with 2 neurosurgical microscopes and 1 C-arm. Kosovo has 12 neurosurgeons, 8 working in University Neurosurgical Clinic, and 4 senior neurosurgeons work in private practice. They mainly perform spinal surgery. There is a group of 8 residents admitted in our clinic last year, just a few months before my retirement. Our hospital has MRI, CT, and DSA. In our institution, yearly, it's performed 650 to 700 surgeries per year.
Oh, Alcim,
yes.
The slide, do not move.
Pardon?
Still first slide.
First slide.
Slides are not changing, Professor.
This,
Can you change the slide, please?
it's now better?
No,
Mr.
no.
Arsen, please make a full screen of your presentation.
Full screen. Full screen.
There is a flask shape in the bottom. There is a flask shape
Is it full screen
icon.
now?
No, Professor, there is a flask shaped icon below the current screen. You can click that and make it full screen. Now you have unshared your screen. Kindly share it again.
Yes.
Yes, now we can see
Yes.
that.
You can see.
Yeah,
Yes.
thank you.
Okay. In our institution, yearly is performed, I say, 650 to 700 surgeries per year. As you can see on a slide, these are data of operation regarding the pathology a year before pandemic. So mostly performed surgery are spinal, after that neuro-oncology and neurotrauma. Our society was taking active role in national and regional continuing education. Pandemic has significantly disrupted the activities. So the last Congress of Pan-Albanian Neurosciences has held on March 2018 in Pristina, and last regional course of topic management and spontaneous cerebral hemorrhage in cooperation with neurologists, neuroradiologists, anesthesiologists was in June 2019. Our society this year had pleasure to welcome as guest lecturer in Pristina my mentor, Honored Vinko Dolens. I must mention as well the neurosurgeons and residents of our center are attending to webinars, and they participate in European, in world seminars, conferences, and congresses by presenting scientific and professional papers. Our training board offers a 6-year residency program. It is in line with EU programs. Education activity were impaired due to pandemia, decreased effective elective surgery, as well as in personal learning opportunities. But the bright side of education, even in my country, is showing that we are moving toward digital age, even though it is mostly personal approach. They are seriously challenging I was to address, like advancing technology, new clinical setting for clinical education, working conditions, finance, and so it's mandatory to provide new residents clinical education abroad for 3 to 6 months in specific fields. Thank you for your attention.
Thank you so much. So your country is heading for the, I think, very good motivation, I think. Thank you so much. Thank you. Thank you very much. So the next, I'd like to invite from the Albania Society President, Mentor Petrella. Is he with us now? He's not here. So maybe I think Dr. Lidban,
yeah.
Can you tell something about Albania, the neurosurgery?
Yes, for sure. I can tell many things. First of all, I want to thank you for inviting us in this very interesting and important meeting. I say hello to everybody who's attending from the region and from all over the world. Right now, we have quite a not very old, but also established neurosurgical teaching program in Albania. We are having two main university centers at the capital of Albania, Tirana. One is at the Mother Teresa University Hospital Center, where I work, and we do elective surgery, and we are involved with the teaching program for students and for the residents. We also have the program for microsurgical teaching for all kind of neurosurgical and surgical branches of our University of Medicine. And we organize courses for them in vascular and nerve repair. It has been running from 2014 with the help of the Irish Society. And we also have been involved with the European Association Neurosurgical Societies training course, which we had the pleasure to host this month in Tirana. And we had more than 200 young trainees from all over Europe and some international invited trainees as well. And we had quite a good experience and success hosting this course in Tirana for the first time. And we have also another university center at the trauma center. We collect all trauma cases, head and spine, and peripheral nerve at the University Trauma Center. They deal mainly with trauma and very much focusing on research as well. They have been involved in international crash study, the three of them that have been also published in the Lancet. We try to keep in touch with many other societies of neurosurgery, and also have been collecting knowledge from we were very young, because the School of Neurosurgery in Albania is established regularly, but 11 years ago. And my generation and those before me were almost obliged to travel abroad and study in other countries. Myself, I studied in Milan, in Italy, for 12 years. And then I made my way back home. So we've been also keeping in touch with the Asian neurosurgeons. I had the chance in 2007 to be invited as a young neurosurgeon to attend the World Federation of Neurosurgical Societies Congress in Nagoya from Professor Yoko Kato here. So I'm thankful about it. It was very special experience. And of course, it is very important for us to continue keeping in touch with other societies in the region, but as well all over the world, in order to know each other and exchange knowledge, which is in the basis of our profession. Thank you.
Thanks so much. So finally, just I would like to invite Dr. Zakiri from Macedonia. Are you with us now? I think not yet. I think. So then we can start. So the senior professor, please encourage each speakers. So just I would like to start. The first speaker is Professor Akitake Mukasa. He is just immediately past president of the Asian Congress, not Asian, Japanese ACNS. So it was really nice, the Congress. He contributed to so many young doctors. So the Professor Akitaka Mukasa he graduated from the Kumamoto University, but he trained and the PhD at Tokyo University. So he went to so many his related hospital, and also he studied the Ludwig Institute for Cancer Research in San Diego, and also department at the University of Tokyo. And he has a special interest in neuro-oncology, especially the treatment of the malignant brain tumors, the molecular genetics and biology of the brain tumors, molecular targeted therapy, and individualized therapy. So image-guided surgery and awake surgery that he has published widely with a special focus on the molecular aspect of the neuro-oncology. So today, the Professor Mukasa will talk the glioma therapy in the era of the molecular diagnosis. Professor Mukasa, please.
Good evening and good morning, everybody. So thank you very much, Professor Kato, for a kind introduction. And thank you again for inviting me this wonderful ACNU webinar. And thank you also for many distinguished professors in other countries. I will share my slide. Can you see my slide?
Yes.
So today I would like to discuss the treatment strategy for various brain tumors, especially malignant brain tumors, which are advancing with the improvement of molecular diagnostic techniques. So actually, recently I had a presentation at the ACNU webinar. So today's talk is a kind of short version of my previous presentation. Sorry for that. And I have no COI to disclose. So first of all, the treatment of brain tumor requires multidisciplinary medical care by people in various positions, as I shown here, and the role played by neurosurgeon differs from country to country. So in Japan, neurosurgeons are deeply involved in medical treatment other than surgery, which also requires knowledge of molecular genetics. So in any case, I believe that the knowledge of molecular classification and treatment planning based on the molecular information will become more important in the future in many countries. And that is what I would like to talk today. So molecular diagnosis has allowed us to predict the malignancy of glioma and the patient's prognosis more accurately. So this is why the 2016 version of the WHO classification of central nervous system tumor was such a revolutionary change, incorporating and molecular information as an essential part of the diagnosis. So in this revised edition, some pathological diagnosis will be described by adding information on the genetic abnormalities to the histological type. For example, as I shown here, diffuse astrocytoma IDH mutant. And if the molecular information cannot be analyzed, it should be described as NOS, that means not otherwise specified instead. So this is a diagnostic flowchart according to the 2016 WHO classification, and it requires the determination of IDH mutation, 1p19q-LOH, and so on. The problem here is that not all hospitals are able to perform these various genetic tests, and the situation varies from country to country as to whether the test is available or not. So this is the seminar with the Asian Congress Neurosurgery, and at the 2018 Society of Neuro-Oncology SNO meeting in US, I moderate a session organized by Asian Society of Neuro-Oncology, ESNO, and we discussed the issue of molecular diagnosis in Asia. The need for centralized testing in resource-limited countries and inexpensive alternative testing methods such as immunohistochemistry, as surrogate markers, and others were mentioned as a possible solution. So now one of the questions for neurosurgeons in this era of molecular pathology is whether there is a difference in treatment strategy between astrocytoma and oligodendroglioma, for example. And in this case, several studies have retrospectively examined the impact of surgical removal in molecularly diagnosed astrocytoma and oligodendroglioma, and most of the study found that the prognostic significance of maximum resection was higher for astrocytoma. For this reason, so in a recent review, the significance of removal without residual tumor to prolong survivals is stated to be most significant in astrocytomas. So that means the molecular information may impact the surgical strategies. So then the next question is whether it is possible to predict the molecular diagnosis before surgery. So today, because of the time limitation, I will not go into detail, but there is a list of promising less invasive genetic and imaging diagnostic method to achieve such a goal. For example, that MRS, T2 flare mismatch, radiogenetics, as well as liquid biopsy. So genome analysis of cancer is advancing, and as former President Obama in the United States declared in his precision medicine initiative, we are now entering the era of cancer treatment using genome information. So actually, there are many potential molecular targets for brain tumor, especially glioblastoma, as shown here, but only a few of them we can use in the clinic. For diagnosis, in Japan, 2 cancer multi-gene panels are available as a part of cancer genome medicine, and one of them is Foundation 1. And among genetic abnormalities that can be analyzed by Foundation 1, the following table, as I show here, lists the genetic abnormalities associated with brain tumors. So unfortunately, the number of those that are relevant to treatment is still small. So as diagnostic method for cancer genome medicine have progressed in this way. So the WHO classification of CNS tumor was again revised last year to the 5th edition, and more genetic abnormalities are now considered important in diagnosis. As I show here, there are many kinds of tumor needs a molecular diagnosis. So in glioma, adults and children are now classified separately, with the children being further subdivided and several new diagnoses added. So this is a schema of adult glioma and genetic abnormalities. The term anaplastic, which used to be for grade 3, is no longer used, and the grade of malignancy is indicated by an Arabic number instead of a Roman number. So in astrocytoma, diagnosis of grade 4 is made when there is a homozygous deletion of CDKN2A and B. So in this case, it is called astrocytoma grade 4, not as previously called GBM. So in IDH wild type astrocytic tumor, grade 4 can be diagnosis in absence of necrosis or microvascular proliferation if there is either TAT promoter mutation, EGFR amplification, and chromosome 7 amplification and chromosome 10 deletion. So for the diagnosis of low-grade glioma, so detection of CDKN2A and B is diagnostic very important. So CDKN2A and B is an important gene encoding both INK4A and ARF. Both of them involved in cell cycle regulation, and those are located on chromosome 9. So there are many ways to determine CDKN2A and B deletion, but we now use the MLPA, so multiple ligation dependent probe amplification method, which is relatively inexpensive and useful because it can also determine the EGFR amplification and on the chromosome 7 and P10 deletion chromosome 10, which are necessary to diagnose molecular GBM. So in pediatric low-grade glioma, abnormalities of MAP kinase pathway have been identified in a variety of tumor and have been incorporated into the new WHO classification of CNS tumors. So the BRAF V600E mutation and its fusion with KIAA is characteristic of pyrocytic astrocytoma, and this can activate the MAP kinase pathway also. So in addition to BRAF V600E mutation are found in various brain tumor, such as Limbic-System astrocytoma, PXA, ganglioglioma, epithelioid GBM, and papillary craniopharyngioma. So this BRAF mutation is clinically important because there is a very good inhibitor against the BRAF pathway. But inhibition of BRAF is known to cause a resistance due to activation of other pathway. So it is reported to be effective to inhibit not only BRAF pathway, but also MAP kinase pathway. So in this context, combination therapy with the BRAF V600E inhibitors and MEK inhibitors, which both can inhibit the MAP kinase pathway, has been tested in clinical trials and has shown some efficacy, promising efficacy. So on the other hand, MEK1 inhibitor have been also tested in glioma with BRAF pathway alteration, which also showed the promising results. So this is our patient with PXA who underwent gross total resection at the first surgery. And but the tumor recurred, and she then underwent reoperation and chemotherapy for recurrent tumor. The recurrent tumor showed an anaplastic feature. The tumor recurred again, though, and we performed the cancer multi-gene panel test. In this case, the Foundation 1 CDX. And we could confirm the BRAF V600E mutation in this patient, and the tumor also showed the loss of CDKN2A and B. So this patient received the BRAF V600 inhibitor dabrafenib with the MEK inhibitor trametinib, which resulted in the significant tumor shrinkage, as I shown in here in MRI. So these BRAF alteration and genetic abnormalities that we must always be aware of. So one of the new tumor type added to WHO 2000 21 classification is infant type hemisyphilic glioma. So this is a group of tumor with ALK, ROS1, NTRK1-3, and MET mutation, and which is important because that can be targetable by NTRK inhibitors. So NTRK fusion gene is activated and upregulated to downstream signaling, resulting in accelerated tumor growth. So there are several NTRK inhibitors that have demonstrated significant tumor shrinkage in basket trials in variety of NTRK fusion positive tumors. And also several clinical trials of TRK inhibitors such as entrectinib underway in clinical trials in fusion positive CNS tumor, and some of them show the complete remission, and such high response rate make it very promising agent. So because of that, the identification of NTRK alteration is very important to treat the glioma patient. However, the problem is that the frequency of NTRK gene fusion is very low, as you can see here. So in children, the mutations rate is relatively high, and seeing about 40% of non-brainstem high-grade glioma younger than 3 years of age, which may correspond to the new WHO classification infant type hemispheric glioma, but these populations are still very low. So recent recommendation published in ESMO suggests that the next generation sequencing should be used for confirmation, but the immunostaining may also be used for screening. So NGS is too expensive to perform for all patients, so maybe immunohistochemistry can be used as a screening tool. So an important abnormality seen in high-grade glioma in children and young adults is histone tail mutation occurring H3K27 and G34. So interestingly, the K27 and G34 have a characteristic site of origin and age of onset, perhaps reflecting their respective cellular origin. So diffuse midline glioma K27M mutant occurs in younger patient than the patient with the G34 mutant, and K27 occurs more frequently in the midline of the CNS, whereas G34 mutation occurs more frequently in the tumor in cerebral hemisphere. So this is our case of 35-year-old patient with a diffuse midline glioma of the cerebellum, and partial tumor resection and chemoradiotherapy with a STOOP regimen were performed. So surgical specimens were analyzed with Foundation-1, a cancer multi-gene panel testing system, and in addition to H3F3A mutation, an oncogenic FGFR1 mutation was identified in this patient. So this FGFR mutation is a potential target for a molecular targeted therapy. So the treatment may be available, but in addition, recent reports have shown that the diffuse midline glioma 227 mutant with a mutation with FGFR1 have a considerably better prognosis than the patient without FGFR mutation. So this is I think the good example of the importance of knowledge of genetic abnormalities in predicting patient prognosis and developing treatment strategy for each patient. So 2 new tumor types have been added to the list of embryonic tumor in the WHO 2021 classification, and one of which is CNS tumor with B-core internal tandem duplication. So this tumor is classified an embryonic tumor, but there is still no consensus on whether it is neuroepithelial or mesenchymal neoplasm. So this is our case of 3-year-old boy with B-core internal tandem duplication of the cerebellum. So I will show quickly the video of the operation. So there was a soft tumor inside. Then inside the tumor, that the tumor showed abundant bleeding, but border between the tumor and brain was not very clear. But the tumor was covered by thin membrane. So those are the border between brain and tumor. And intraoperative pathology shows that this thin membrane also contained many tumor cells. So we have to carefully remove those membranes extensively. So since this tumor tissue showed the finding characteristic of tumor type, of this tumor type, B-core staining was performed, which showed the high expression. The further sequencing confirmed that the internal tandem duplication of B-core exon 15, confirming the pathological diagnosis. So in general, MRI image shows these are the typical MRI imaging and clear tumor borders, and average age at initial diagnosis is 3.5 years. The tumor is mainly located in cerebellum or cerebral hemisphere, and the prognosis is presumed to be very poor. So in most tumor, B-core exon 15 internal tandem duplication is the only abnormalities. So B-core is known to non-epigenetic regulator that binds to PRC1 complex, and its function is known to be altered in a variety of tumor, including sarcoma. So although no standard treatment has been established, previous reports suggest that the dissemination is relatively rare in primary tumor, and that the local control is very important. So therefore, craniospinal irradiation was not performed in this patient, and the treatment consisted with platinum-based multi-agent chemotherapy, and local proton beam irradiation was performed. So this patient, I think, suggests that the identification of genetic abnormalities and accurate pathological diagnosis could help in planning the patient, the treatment. So CNS tumor with B-core ITD were originally classified as CNS PNET, but these tumors were discovered as a new cluster by methylation profile analysis in this paper. So recently, the classification of tumor based on methylation profile has been reported to be potentially more accurate than diagnosis by pathologists, and we believe that understanding of methylation profile in addition to genetic abnormalities will become more important in the future. So this is a take-home message, and molecular information on brain tumor has a significant impact on treatment decision, and neurosurgeons need to learn this knowledge. And for many Asian countries, it is necessary to establish a relatively simple method of molecular diagnosis such as immunohistochemistry as a surrogate. Thank you very much for your kind attention.
Thank you so much, Professor Mukasa. It's very difficult but very important issue for glioma, the treatments. So just I want to ask Dr. Ibrahim, any question?
Yeah, actually, 2 comments. Thank you, Professor Mukasa, for wonderful presentation and to remind us for all these genetics we find during the glioma and oncology surgery. It's not only the surgical technique, it's actually the 2 much bigger problem with treatment of gliomas, of course. However, you show us that recently ways how to treat the gliomas after the surgery and also after the only biopsy. But 2 actually question. As we know, the last year was published last version of World Health Organization classification in 2022, which is actually 5th edition, actually 5th change edition of the classification. And they have some small changes, especially for the gliomas. And as you know, they say there is no typical IDH positive, which is better option for glioblastoma, and there is only wild type and so and so. However, it doesn't mean that we will change our strategy for the surgery of glioma. I still believe that we should perform the supratotal resection wherever we can, as Professor Defoe wanna say usually. So do you think that we are still on the way to make the supratotal resection, even if we believe that it's, for example, astrocytoma grade 2 or grade 3, or we should change our strategy to be a little bit less invasive than usually concerning new classification?
Thank you very much for your question. So I'm not quite sure whether we should perform the supratotal resection for all the patients. So for for low-grade glioma, such as oligodendroglioma, that in the slide that I showed that gross total resection is not always required. So when the tumor located on the critical region, so the message from those literature is that we should not resect the patient very aggressively. So we do not have so much risk for the patients. We should avoid the procedure that may cause the paralysis or aphasia. So I think that the molecular diagnosis is can change the strategy for the surgery, I think, and the accurate diagnosis is important.
So you think that the future investigation will drive us how to make decision to be aggressive or less invasive, less aggressive? It depends on the pathohistology probably in the future. So I hope that we will in the close future have some kind of blood testing before the surgery. I hope that, or maybe CSF findings, which will show us which kind of tumor is there, so we could be prepared before the surgery to make only the biopsy or to go to the more radical, because we know that if we want the glioma, then we will have the problem how to start with the resection. Sometimes it's not so easy to start with the glioma resection because it pushes us to go forward, and then we made the resection even much bigger than we want at the beginning. However, thank you for this nice lecture.
Thank you very much, Ibrahim. So maybe one more additional, maybe Dr. Arion, do you have some question to Professor Mukasa?
Good afternoon to all of you there in the eastern part of the world, and then good morning to colleagues in Balkans. I'll take a point from Ibrahim and then move on to what Dr. Mukasa said. So Mukasa Sensei, thank you very much. It's a wonderful topic to put together molecular studies and then bring to the question of Ibrahim. How do we deal with gliomas? This is a pertinent question now in North America. Using molecular studies, it's not always what we do every day. The problem is when we have enough information, we base on that information what we are going to do in regard with the quality of life we provide to the patient following any treatment procedure. So removing a glioma, not necessarily a challenge, but deciding to remove or not and when to remove a glioma is the point of care when we deal with patients in North America. Not many treatment avenues when it goes beyond surgery. We still stand on most likely on therapies that have not been changed since, I should say, at least the last 10 years. The new classifications on gliomas open doors to avenues that may offer windows to research in how we can treat better. But as of currently, not necessarily surgery or radiosurgery remain solutions anymore once we know how what the type of the lesion is. As if for the diagnosis, we are not necessarily always successful to use liquid biopsies only from blood. Not that we cannot conduct a CSF work, that is possible, but if we can arrange to have an accurate diagnosis from liquid biopsies from blood, then we move forward from there. The standard of practice is with what we offer our patient in balance with the quality of life. Is it better to proceed with surgery, a combination of surgery, radiotherapy, and chemotherapy, or none? We actually have to choose to do nothing if the quality of life pertaining to any of the avenues we might offer is no better than having the patient to decide to do nothing. We have to convey the message sometimes that is such painful, and that in case with glioma, especially those that reside infratemporal, including the brainstem, in most of those cases, unfortunately, we have not much to do, and the quality of life remains the same following surgery or radiosurgery or nothing in a frame of 4 to 6 months. So we choose sometimes to do nothing. So thank you, Ibrahim, for bringing that point of surgery subtotal. Usually is the word, but whenever we can, sometimes we don't do surgery at all. Thanks.
So any comment from Dr. Mukasa?
Thank you very much for your helpful comment.
So thank you very much for the dedication of the glioma treatment, especially the molecular diagnosis. I think good prediction for the patient, maybe the prediction of the tumor behavior and also maybe prognosis of the patient in the future. More or less invasive for the glioma, the patient is very happy for them, I think. Thank you very much, Professor Mukasa. So all the best wishes to your future career. Now I proceed the next presenter, the doctor from Hu Jie from Hu Jie from Ocean Hospital from Shanghai. He is studied at the University of the Southern California, the USA. And also he studied also the Hong Kong, and he is a vice president of the Shanghai Association Against Epilepsy. And research interest is functional neurosurgical disease, especially epilepsy or movement disorder. So today he is going to talk the best of transposition, the microvascular completion surgery for primary trigeminal neuralgia. Please.
Thank you. That's Yoko Tato. Hello, everyone. I'm Jie Hu from Department of Neurosurgery, Huashan Hospital, Dan University, Shanghai, China. I'm very, it's my great honor to be invited as a speaker in this important webinar. My topic today is vessel transposition in NVD for primary trigeminal neuralgia. As we know, NVD surgery has long history, more than 50 years. Nowadays, NVD was accepted worldwide. Comparing with other treatments, NVD show the best long-term results, even 5 years after NVD surgery. More than about 75% patients remain good results. But for the other treatment, including radiofrequency thermotherapy, gamma knife surgery, and glycerol injection, for this kind of treatment, the effect after treatment declined very quickly. Interposition is the most common technique in NVD surgery. Usually place Teflon between a feeding vessel and the trigeminal nerve. Although most patients after NVD surgery remain good results even after long-term follow-up, about 10% to 30% of patients will recur after NVD surgery. The operation of recurrent TN patient after NVD is a great challenge. It's a difficult problem for each NVD neurosurgeon. How difficult is the operation of recurrent TN? What a challenge it is. I will show a short video of the operation of recurrent TN patient. This is recurrent TN patient. This video is the operation after TN recurred. Severe adhesion among vessel and nerve and Teflon.
So Dr. Fu, we cannot see the video. Dr. Fu, so we cannot see the video.
Cannot see the video.
We cannot see the video.
Sorry. Can you see now?
No, not yet.
Maybe.我共享屏幕了。Sorry. What's wrong? 消失，这屏幕全消失了，就幻灯也没了。
Perhaps you have to make full screen and the video will start automatically.
幻灯也没了。我操！怎么弄法呢？确实，哦，在这儿。先停止。
So, okay, so you want to start from the beginning?
看得到吗？哦，可以。
Please start.
Wait, just a minute. Sorry.
So can you start again, or?
I will try.
So maybe do you need some time?
1 minute. 1 minute more, please. Sorry.
So Kubota Sensei, you raise a hand. So okay, so maybe you can I'll give you some time. So maybe after the Professor Kubota, the presentation, you can restart again. Is okay? So I will introduce the Professor Kubota.
Okay.
Yuichi Kubota.
Okay.
Yes. So he is the neurosurgeon, and he is from Tokyo Women's Medical University, Tokyo. So the fellowship at the Epilepsy Center, the Cleveland Clinic, USA, visiting fellow, and the Timone Hospital, France. So he went to 2 places as a fellowship. And recently he became a professor and chairman of the Tokyo Women's Medical University. So today his talk is a temporal lobectomy and its microanatomy. Yes. Sensei,
okay.
Can you start, please?
Nice to meet you. Nice to meet you. Okay, so I will share the slide. Can you see my slides?
Yes, but it's oblique.
Oblique? Can you see? No?
We see it, but it's obligatory position. Could you put it in the right position? Looks oblique.
Once more time, I will share.
Yeah, guys, that's good. That was good.
Sorry. Can you?
Yeah, we see now. Just share the full screen, please.
Full screen, okay. Okay.
Not yet.
So slideshow, please.
Okay.
No, not yet.
So you cannot see my slides,
Yeah,
right?
We can see.
Okay, I will do
full screen,
again.
please.
Okay. How about this?
Again, the same. But we can see your slide.
Is it
Not full screen.
not full screen? Oh, I don't know. How about this?
Yeah, no, not yet. But we can read, so you can start.
Okay. So hello everybody, and nice to see you. This is Yuichi Kubota from Tokyo Women's Medical University Medical Center. So it's my great honor to have such a great opportunity to second ACNS with Bosnia and Herzegovina, Albania, and Kosovo. I really appreciate Professor Yoko Kato and other organizers. Today, I would like to talk about temporal robectomy and its microanatomy. So I have no COI. So first of all, briefly, I would like to introduce myself. I graduated Yamagata University and trained neurosurgery in Tokyo Women's Medical University. Since 2009, I have been studying at the Cleveland Clinic
Epilepsy Center in the United States and the Timon Hospital in Marseille, France, for further study of epilepsy surgery and neurophysiology. Now I became a professor of this hospital. So Tokyo Women's Medical University, one of the largest high-volume center in Japan, we have a main campus in Shinjuku, distinct, and Adachi Medical Center in Tokyo East area, and Yachiyo Medical Center in Chiba Prefecture. The total number of beds in all hospitals approximately 2,000 beds. In 3 hospitals, we have more than 2,000 neurosurgical cases per year, including tumor, cerebrovascular, and functional neurosurgery. So my center is founded in this year, a relatively new hospital. We had more than 500 beds. We belong to WFNS Neurosurgical Training Center, so we are always welcome international neurosurgical fellow. So my topic is temporal lobectomy. Temporal lobectomy is one of the established neurosurgical procedure for medical temporal lobe epilepsy. So usually for non-dominant site, you can take up to 6 centimeters from temporal tip. On the other hand, for dominant site, you can just take up to 4 centimeters from temporal.
Kubota Sensei,
yes?
Please proceed your slides.
I'm sorry?
スライドを進めてもらっていいですか？
Can you see my slide?
今見えてます。それの前かな。
Okay.
それでいいですか？
Temporal. Can you see a temporal?
Yes, we
row?
can see.
Okay.
Thanks.
Okay. So a non-dominant side, you can take 6 centimeters from the temporal tip. Then on the other hand, dominant side, you can take up to 4 centimeters from the temporal tip. So this table shows the superiority of temporal lobe resection surgery compared with the usual medical treatment, which showed in New England Journal of Medicine 2001 from University of Calgary, Canada. The percentage of without impaired awareness seizure surgical case was 55% seizure free. On the other hand, but 80% seizure free was achieved in medical group. So that is only the randomized controlled trial in the field of the epilepsy surgery. So let me show the
Professor
video.
Kubota. Professor
Yes?
Kubota.
Yes?
Sorry, we still have the same slides, so you don't change, you cannot change the slides. Maybe I could help you to adopt the presentation. Yeah, you should go by hand or try something I could show you. I could help you maybe.
Okay. So now can you see my video?
Yeah, we can see. Please
Okay,
click.
so now, okay. So let me show you video. So firstly, I want to show standard anterior temporal lobectomy. So this patient was a 50-year-old man with hippocampal sclerosis. He had presented with frequent impaired awareness seizure, nevertheless polypharmacy. So after the temporal...
Video does not move. Video does not move.
Oh my goodness. So again...
Let me share my screen to show you what you should try to do, and you will have the chance to show us all the slides. Is okay?
So you cannot see the video still?
No, it's not on full screen. It's like the preparation for the full screen for the presentation. So go to the I don't know in Japanish, but for
okay, just you can put a click there. そこを押してください。はい。
Can you see?
はい、大丈夫。大丈夫。
Okay. So now after the temporal craniotomy and the dural opening, so now we measure the 40 centimeter from the temporal tip. This is the left side. So prior to the dissection, we always measure the electrocorticogram from the lateral temporal cortex. And then we coagulate the corticotomy in T2, middle temporal lobe gyrus. And then we enter to the inferior column. Then after the opening the inferior column, the CS phase is go out, and then brain is slacked and very easy to do surgery. Then after that, temporal lobe cut from the T2 and the T3 up to the collateral sulcus, this way. Now you can see the collateral sulcus right here. And then now we go to the Sylvian fissure this way. Then now we take the T1 superior temporal gyrus by CUSA, not to injure the peer matter. So at this point, please take care not to injure the MCA. Now you can see the M2 like this way. So now we go to the inferior limiting sulcus, the bottom of the insular cortex, like this way, subpially. Then we connected the superior aspect of the inferior column and the bottom of the insula. I mean, we cut the temporal stem like this way. Now you can see the choroid plexus inside the inferior ventricle. So then after that, here is a collateral eminence. So we enter the collateral eminence and by CUSA or sonapet laterally. So hippocampus is over here, right here. Then now we reach to the middle cranial base. So eventually, finally, we can take the lateral part of the temporal lobe. So after taking the lateral temporal lobe cortex, we started to medial temporal resection. Now you can see the hippocampus. So usually hippocampus was taken from 2.5 centimeter from the hippocampal head. So now we open the choroidal fissure very carefully. Here is a hippocampal choroidal fissure. It's the same thing, not to injure the pia matter of ambient system. Here is ambient system. So usually here is the inferior choroidal point, which is enter the anterior choroidal artery to the ventricle. So this is the choroidal fissure, and the inferior choroidal fissure is right here. So this is enough resection area. So now we cut the posterior resection area of the hippocampus. So now I excised subpyally the fimbriae from the pia, like this way. Now you can see the PCA. So hippocampal artery come from the PCA to the hippocampus. Then I gently coagulate the hippocampal artery and cut like this way. Then sometimes, usually the hippocampal artery can be coagulated 2 or 3 times because the several artery come into the hippocampus. At this moment, coagulate power decrease very low, not to damage other critical vessels. This is the hippocampus resection. Then finally, I took the amygdala. Amygdala can be taken just one inferior part of the amygdala, like this way. And that's all the temporal resection. And then finally, I again measure the electrocorticogram from the posterior part of the temporal lobe, not to find any epileptic activity. Then after surgery, this patient no seizure at all, so for 6 months. Okay. So in my center, this technique can be used for stroke. This is a cases of MCA area infarction. So this brain was extremely swelling because of infarction, and we did temporal lobe resection. So this is a preoperative, and this is a post-operative CD. And also, you can use this technique for tumor surgery as well. So this MRI shows glioblastoma in left temporal lobe. So following temporal lobectomy, this patient is now on the stop regimen, temozolomide, and radiation therapy. So about microanatomy, my previous teacher, Holly, described the detailed microanatomy of temporal structure. The preformed lobe is made up of the entorhinal area and uncus. Intralimbic gyrus, uncinate gyrus at uncus, and gyrus of androretris here at the hippocampal tail. The superior part of the dentate gyrus with the band of Giacomini and the margo dentarius. On the superior ankle surface of the anterior choroidal artery follows the sulcus semi-annularis, separating the semilunar gyrus from the ambient gyrus, and penetrating into the terra choroidea at the inferior choroidal point. The ambient gyrus show a marked ankle notch produced by the free edge of the tent limb. The curved arrow indicates the ankle sulcus.
Professor, we don't see your slide. Can you go, please, for a full screen?
Okay. Can you?
No, it is the same. It is the same. The problem from the early beginning. So could you have the 30 seconds just to show you what to try and how you can manage this problem? We cannot see the slides which you are talking about. So if you're gonna on your presentation on the this position, I don't know in Japanish, but
yes,
just
we can see your slides. So just
Can you see?
Yes, please. Yes, please proceed, I think.
Okay, so now we're talking about the artery. So usually the anterior colloidal artery runs along the semi-annular sulcus of the uncus and enters the colloidal fissure posteriorly. And the anterior hippocampus artery enters the uncal sulcus and typically has anastomosis with the anterior colloidal artery. And also this is a superior view of the hippocampal body. The middle and posterior hippocampal artery typically originate from the PCA, posterior cerebral artery, like this way. The P2 portion of the and enter the hippocampal sulcus. They form the arterial plexus in the hippocampal sulcus. This is a little bit complicated, but usually most of the hippocampal artery come from the posterior cerebral artery. So this is very important, not to coagulate other vascular vessels. So recently, we introduced the minimum invasive temporal lobe resection. We just make a 10 centimeter skin incision. The patient can be shaved just partially or sometimes no shaving. Skin incision, we can check the cerebral fissure, the neural navigation system, and a 5 to 10 centimeter semicircular fashion from the root of the zygoma. The usually STA, superior temporal artery, superficial temporal artery is basically preserved. So this is a post-operative photo. Patient can do not suffer from the cosmetic problem. So usually this is we have sometimes we have a point open the inferior column from the T2 under the navigation and the vertical cutting of the temporal lobe and the subpiral exploration of the cerebral fissure and the temporal trunk disconnection and the temporal lobe lateral remove and the uncus, hippocampus, amygdala removed. So this technique's advantage is short surgery times and low infection rate, probably. And also there is no pterion dent and it is good for shaping. And also early rehabilitation is possible and the patient can return the previous job as soon as possible. On the other hand, disadvantage is a restriction of the surgical field. You can see that sometimes lateral temporal is very difficult to take from the bone window. So that is all, and thanks for your attention. And also I'm sorry to some problem of the Zoom.
Thank you very much, Professor Kubota. Nice presentation. So just I can take one question.
Yes.
Dr. Please. Dr. Radivan? Radivan? Yes.
Thank you for this very interesting presentation. I have been involved early in my residency program on epilepsy surgery, and it reminded me of those very beautiful times. And my question would be about how could we also, in case of glial tumors, apply such technique? Is it also applicable in cases of glioma, temporal glioma, low-grade gliomas, to remove with the same technique the hippocampus and amygdala, or it is only for the cases of no lesioning epilepsy?
Yes, you can use this technique, especially for non-dominant hemisphere. I mean, usually is mostly the right side. But on the other hand, the left side, patient has a function in usually the glioma surgery, glioma patient. So that is another point. Usually, if the patient the glioma located in the left, I mean the dominant hemisphere, you may be preserved. You may preserve the hippocampus, not to decrease the memory loss.
Thank you.
Is it okay? Thank you very much. So nice guidance. So the minimally, especially minimally invasive, the treatment is, I think, ideal in future, the epilepsy surgery. Thank you so much.
Thank you.
So
Thank you.
for the next one, I move to the next one is Professor Tan Dong Shen. He's again from Foshan Hospital in Shanghai, the biggest hospital in China. He's going to talk intraoperative mulch information guided surgery for insular glioma. Professor Tan. Professor Tan. Or Dr. Ji, are you ready?
Yeah, I'm ready.
Okay, yes, please, go ahead.
Can you see my slide?
No, not yet.
Not yet. Can you see now?
No, not yet. Now it's okay. Please, slideshow.
Can you see my slide?
Yes, we can see.
Yeah, okay.
So,
So I'm very sorry for the video problem. Now I will continue my talk.
Dr. G, full screen, please.
Oh, okay. This is I will play the video first. This is from recurrent TM patient, the second operation, second MPD surgery. During operation, fairly severe adhesion among vessel nerve.
Sorry, we cannot see the video.
Cannot see video?
Yes, cannot see video again.
Professor Kato.
Yes.
If you allow me to show what they probably should do.
Please go ahead.
I'm sorry, Professor Hu, I will share my slide for 1 minute just to show you what you can try to do, because we have this problem probably all the day. So when you're gonna I will try to share it, because so I will share one of my screen, for example, this one. Could you see my slides now?
No, not yet.
No.
It's fine.
It's any. You see the slide? I mean, clear slide.
Yes.
No.
Yes, just go. You see the pointer on the screen?
We see the Word document. You should go back to Power Presentation. This is Word document. Or maybe it's the best option when you open the presentation, just press F5 on your dashboard and you will work.
What do you see now, Adi?
It's presentation, just make a full screen.
Yes, they have to go here, but I know in Japanese, on Chinese, setup slideshow is fourth from the left. So slideshow, then set up this one. And when you gonna there, you have the presented by a speaker, the first one option. Could you see that? This is all usually problem with the Zoom server. So fifth from the left, and then set up slideshow, and then first. Could you see that, Adi?
Yeah, we do. I'm just
I hope it's understandable. And then they could show us full screen. Please try that. Sorry. Thank you.
So can we try again?
Yeah, please go ahead, Professor Yu.
Can you see my slide now?
Not yet. We are waiting for.
Can you see my slide?
Not yet.
Not?
Not yet.
Not yet. So can you see?
Now we see presentation. Just go for the full screen, please.
So can you see my video?
We do. Now we do.
Very sorry for my video problem. So I will continue my talk. This is a recurrent TM patient after MVD surgery. We can observe the very severe adhere among vessel, Teflon, and the nerve. So for such kind of the operation is full of challenge for neurosurgeon and full of risk. We have to pay special attention to avoid the damage to nerve and to vessel. So the question is, what should we do in the first operation, in the first MVD surgery? What should we do to avoid severe post-operative adhesion? And how can we reduce recurrence? What we should do in the first operation, in the first MVD? And so I will temporarily stop the video here. In order to reduce the post-operative recurrence, we should understand what the main causes of post-operative recurrence. In our experience and according to the literature, post-operative adhesion and granuloma formation around the decompression site is the main causes. We usually can observe the very severe adhesion. This paper, the author reported a series of 15 cases, which is recurrent TN patient during the second MVD surgery. Neurovascular adhesion with Teflon was observed in 73% of patients. So the adhesion is the main causes of recurrence after MVD surgery. The Teflon is the most commonly used material for MVD surgery. The Teflon has some advantages, including the biologic safety, good plasticity, and can be made into fluffy form. But it's almost impossible to avoid adhesion. Usually, severe adhesion can be observed during the second operation. Sometimes, in some cases, also granuloma formation can be observed. So, if we want to avoid or reduce post-operative recurrence, what should we do, especially in the first MVD surgery? The vessel transposition technique is a very effective and useful method, which can prevent adhesion and granuloma formation due to not interposing any material between nerve and the vessel. There are several main methods of vessel transposition, including setting a level bridge, hanging a feeding vessel, sticking a feeding vessel with glue. Example of setting a lever. The feeding vessel is a vertebral artery, compress its branch, then compress trigeminal nerve. And this is facial acoustic nerve. For this case, the Teflon was placed between a feeding vessel and the brainstem. The Teflon at this site acted as a lever to lift a feeding vessel, so a large empty space was created, no material between vessel and the nerve. Another example of setting a lever, the feeding vessel is CA. For this case, the Teflon also placed between the vessel and the nerve, so the Teflon acts as a lever to lift a feeding vessel, no material between vessel and the nerve. Example of setting a bridge, this case, the vertebral artery compress acoustic facial nerve and then compress trigeminal nerve. For this case, Teflon were placed at two sides, the proximal point the proximal end of affecting vessel and the distal end of affecting vessel. The Teflon at least two sides together with affecting vessel looks like a bridge. So no material between trigeminal nerve and affecting vessel need to place. Hand technique. This picture shows affecting vessel is CA. Yes, CA was sutured onto tentorium. But usually in MPD surgery, a small, very small incision and a very small bone window was used. So perform suture in a deep location by a small bone window is very hard. So this technique rarely used in our center. This paper reported another kind of hand technique. This is autologous tissue strip. The strip is of autologous tissue surrounding, encircled around the affecting vessel and sutured onto petrous bone. This case from our center, affecting vessel, large vessel, maybe vertebral artery, compressed nerve, and then the affecting vessel was hanging. Used the artificial dura. The strip is made of artificial dura were used to suture onto the posterior wall of petrous bone. And other hanging technique was reported. The polytetrafluoroethylene belt were used. This belt has a hole in the wide end, and the left end tipped into a point. So the belt encircled around the affecting vessel by inserting pointed end into the hole, and then the pointed end passes through dural tunnel, and then tied all three times. Double stick tape technique. A collagen fleece coated with fibrin glue was used to transpose affecting vessel. This double stick tape stick affecting vessel onto petrous bone. Another hand technique, sling wing transposition. Firstly, made a dural incision on the posterior wall of petrous bone. So a petticoat dural flap were made. This petticoat dural flap encircled affecting vessel and then sutured onto posterior wall of petrous bone. First, they made a petticoat dural flap, encircled affecting vessel, and then fixed on the posterior wall of petrous bone. Borderline technique. This technique is similar to the double stick taper technique. A collagen sponge, which soaked with fibrin glue, was used to transpose affecting vessel. Sticking with EC glue is a very simple and effective way for transposition. The affecting vessel, example of sticking with EC glue, vertebral artery, compressed nerve, and then the vertebral artery sticking with EC glue onto the posterior wall of petrous bone. Another example, the vertebral artery sticking with EC glue on the posterior wall of petrous bone. Example of sticking with fibrin glue. The affecting vessel is on the ventral side of trigeminal nerve. Firstly, we move affecting vessel to the left side of trigeminal nerve, and then we push the affecting vessel close to tentorium. And then finally, we stick the affecting vessel with fibrin glue onto tentorium. So completely decompression was achieved, no material between vessel and nerve, large space. And another example of sticking with fibrin glue, this case, affecting vessel is SCA. We sticking the SCA with fibrin glue onto tentorium. Another example, SC affecting vessel and sticking affecting vessel. The SCA was sticking with fibrin glue onto tentorium. This case, the affecting vessel is ICA. This ICA also sticking with fibrin glue on the posterior wall of petrous bone. The affecting vessel also is ICA. The ICA affecting sticking with fibrin glue on petrous bone. There are some key steps for vessel transposition with fibrin glue. Dissect a arachnoid membrane for operative space first, and then find a stable place, usually tentorin or petrous dura, to paste. And then clean CSF and arachnoid membrane as much as possible near the pasting site. And do not add too much glue, but enough. Hold for a while until the glue is hardened. Now, I introduce a series of patients which was decompressed by vessel transposition with fibrin glue in our center. Totally 33 cases. This is the age and the sex, site of pain, duration of pain, and the follow-up period. In the 33 cases decompressed by vessel transposition with fibrin glue in our center, preoperative pain duration at least 1 year. About 61% is over 1 year. About 40% of patients is over 5 years, the pain duration preoperatively. The follow-up time, the mean follow-up time is 38 months. About 40% of patients, the follow-up time is over 1 year, and 60% of patient follow-up time is over 3 years. So at least 1 year follow-up time for each case. Most cases, the follow-up time is over 3 years. The surgical outcome of this series of patients treated in our center. The Bellow Neurological Institute Pain Scale. The Bellow Neurological Institute Pain Scale was used to evaluate the surgical outcome. 91% of patients is grade 1, which means no pain, no medication required. And 9% of patients is grade 2, which means occasional pain, no medication required. Generally, very good results was achieved in this series of patients, especially during the follow-up period. No post-operative recurrences was observed. No dysfunction of the cranial nerves were observed in this series. That means fibrin glue, sticking with fibrin glue is a very effective and safe method for transposition. Now, I will continue to play the video posted temporarily in the beginning of the presentation to show what we do in order to prevent post-operative adhesion again, and what we do to reduce the recurrence rate to avoid recurrence again. This case, because of very adhesion is very severe, so a small piece of Teflon was residue. We stick with fibrin glue together with a small piece of Teflon. Affecting vessel together with the small pieces of Teflon was sticking with fibrin glue onto the tentorin. So in this way, no Teflon, no any material was placed between the vessel and the nerve. So this is a very ideal decompression and complete decompression. And in this way, we can reduce the adhesion again, reduce the recurrence again. So the conclusion, vessel transposition is an effective and simple way for NVD surgery, can be recommended for NVD at least in some patients. Our series of TN patients decompressed by vessel transposition with fibrin glue showed excellent outcome and no post-operative recurrence. Vessel transposition may be an effective way to prevent recurrence after NVD. I'm very grateful to all members of my team for their valuable contribution, including Dr. Jiang, Lan, Sun, Cai, and He. Thank you for your attention.
Thank you, Dr. Fu. It was a nice technique, transposition, not insertion, some prosthesis. So just I can take one question. So maybe Dr. Adi, any question to him?
That was an excellent talk. Thank you, Professor Yu. My question actually was how to avoid, in a first surgery, how should we avoid possible adhesions? What is the main cause of adhesions which are happened after the first surgery? Because we also had some of the cases with the post-operative recurrence of the trigeminal neuralgia. So is there any technique we should use, like copious irrigation, avoidance of some of the movements, etc.? And also, I agree that, as I noted in a literature, that current strategy is to use fibrin glue instead of the prosthesis, instead of the Teflon. Thank you. It's just my comment and question: how to avoid adhesions in a trigeminal neuralgia surgery, which can also be followed in pontocerebellar angle tumor resection strategy. Thank you.
So Dr. Fu, question to you.
I think because typical MVD surgery, Teflon is most commonly used, and the Teflon is necessary for the typical MVD surgery. I think the most effective way is to avoid any material between vessel and nerve. This is the most effective way, just to show in my presentation. In this way, we can, to maximum extent, to reduce the adhesion between vessel and nerve, to reduce the recurrence.
Okay, thank you very much. And do you sometimes be careful of the perforators? So when you transposition of the main offending vessels? Dr. Hu?
Sorry?
So do you care for the perforators when you transposition the offending vessels, such as ICA or ICA?
Good question. Vessel transposition is effective way to prevent adhesion and recurrence, but cannot be used for all cases. Only if we use the transposition technique, we should the cases should meet the following preconditions. The first is the vessel should have not branches which limit the movement of vessel. This is one of the preconditions. The second should a relatively large space between vessel and the nerve is required. If the space is too small, you cannot move the vessel. And the third is a supporting site is necessary nearby the vessel and the nerve, because we need a supporting site to pasting the vessel. Usually the tentorium or patches bone as a pasting site.
Okay, thanks so much. So I proceed the next presenter, the Professor Chan. Professor Chan, are you ready to talk? He's the chairman, he's a professor from the Fudan University.
Yeah.
Please go ahead.
Thank you. And good afternoon, everyone. I'm Dong Xiaozhuang, also from the neurosurgical department of Huashan Hospital. Thank you for inviting me to join this webinar. And can I share my screen?
Yes, please.
Sorry. Sorry. Okay. Can you see the picture?
Not yet.
Okay. No. Yeah. Can you see my screen?
Yes, yes.
Okay. Today I'm going to talk about the surgical management of insular glioma with intraoperative multi-information guidance. The insular cortex is a portion of the cerebral cortex folded deep within the lateral sulcus between the temporal lobe and the frontal lobe. We should remember Dr. Rao, who first described this structure in the year 1809. The insula is functionally a complex structure harboring peculiar anatomical and vascular features. It also has specific neuronal connectivity with surrounding cerebral structures. The insular lobe is situated in the depths of the Sylvian fissure and hidden by the opercula of frontal, parietal, and temporal lobe. Deep to the central portion of the insula, from the lateral to medial, we can see here extreme capsule, claustrum, external capsule, putamen, and globus pallidus. Because of the time limit, I'm not going to detail the topographic anatomy of this area. DTI tractography shows the subcortical language pathways surrounding the insula, such as the acute fasciculus, this superior longitudinal fasciculus, the inferior longitudinal fasciculus, the inferior frontal occipital fasciculus, and the uncinate fasciculus. This picture shows the language tracts adjacent to the insular glioma. Here, this is the frontal excellence tract connecting the Broca area and the supplementary motor area, which plays an important role in speech initiation and verbal fluency. In this picture, this is the pyramidal tracks. This technique can be used for pre-surgical planning as well as intraoperative guidance. As an important functional structure, the insula is involved with gustatory, olfactory, auditory, and vestibular senses. It is also involved with pain perception, motor integration, the motor planning of speech, cardio-regulatory, and vasomotor functions. The insula is also adjacent to some important functional structures, such as perisylvian essential language areas, primary auditory area, primary motor area, and primary sensory area, and their subcortical pathways. The main blood supply of the insula is from the short and medium-sized perforators of M2 segment of the middle cerebral artery. There are two groups of important perforator arteries we should pay much more attention during surgery: the lenticulostriate arteries and the long M2 perforators overlooking the posterior insular lobe. Because of the lenticulostriate arteries mainly supply the basal ganglia and internal capsule, and the long M2 perforators mainly supply the corona radiator, particularly the pyramidal tracts. All these anatomical and physiological features of this area pose a significant challenge to neurosurgeons. Then we are going to talk about the insular tumors. The insula is a frequent site of gliomas, particularly those non-enhancing tumors. The insular gliomas account for up to 25% of all low-grade gliomas and 10% of all high-grade gliomas. The main clinical manifestation of these tumors includes seizures, signs of elevated intracranial pressure, and focal neurological deficits such as aphasia or dysaphasia and hemiparesis. This is Dr. Yasagio's classification of limbic and paralimbic system tumors. And this is modified classification of insular tumor by Dr. Ami. But in our clinical practice, we tend to use the Berg-Sane insular glioma classification system. This system divided the insular area into 4 zones along the line of Sylvian fissure and the perpendicular plane crossing the foramen of Monro. Insular tumor location is determined by the location of the majority of the tumor mass. From the axial section, we can see here, zone 1 and zone 4 are located anterior to the foramen of Monro, and zone 2, zone 3, located behind the foramen of Monro. Usually, zone 1 was associated with the highest median extent of resection. The goals of surgical resection of insular gliomas are to help symptom control, to confirm diagnosis, and to improve survival. With the review of literature, for insular gliomas, not only low-grade gliomas, but also high-grade gliomas, it was observed that a greater extent of resection is associated with longer overall survival, progression-free survival, and malignant progression-free survival. Our challenge is to balance the extent of tumor resection and the neurological morbidity. How to balance them? Our solution is what we call the intraoperative multi-information guidance, which includes awake craniotomy, direct electrostimulation mapping, functional neuronavigation, intraoperative neurophysiological monitoring, and intraoperative MRI. The goal of using all these techniques is to achieve a maximal safe resection of this challenging tumor. From 2011 to 2017, 255 insular gliomas underwent intraoperative multi-information guided resection by our team in a 3T intraoperative MRI integrated surgical suite. This is the operating room setup for awake craniotomy in our intraoperative MRI surgical suite. Here we can see the anesthesiologist, the neurophysiologist, the scrub nurse, surgeon. This is the navigation system. And the intraoperative MRI scanner is behind this gate. In our center, the anesthetic pattern, awake or asleep, was selected based on the hemispheric dominance and the tolerance of the patient. So awake craniotomy was preferred for dominant-sided lesion without contradictions to awake anesthesia. But for those patients unable or unwilling to cooperate with awake craniotomy or have evidence of severe intracranial hypertension, then general anesthesia was selected. Then a tailored frontal temporal craniotomy is performed via the terional approach. The bone window was adjusted to fit the tumoral extension. After opening dural, a subdural strip electrode were placed to locate the central sulcus and then continuously detect the motor evoked potentials. Here we can see the central sulcus is between the electrode 2 and the electrode 3 by the SSEP. Then language and motor cortical mapping is performed. Functional cortical areas are labeled with this stereo text. Here we can see 1, 2, 5 represents speech arrest, 3 represents the dysarthria, M represents the mouth motor area, and 6 to 9 represents anomia. Under neuronavigation, the tumor border is identified and marked with silk sutures. It is very important to choose an ideal approach to expose the insula. In our practice, for purely insular tumor, a Transposition approach was employed. For tumors with opercular extension, a transcortical approach was preferred. But for those large or giant insular gliomas, a combined approach, which means dissection of the Sylvian fissure followed by resection of non-functional frontal temporal opercular, was performed for better exposure. Then, tumor resection was conducted under the neuronavigation and intraoperative neurophysiological monitoring. During resection, The margin of the tumor was identified by the surgeon's intraoperative observation and structural neuronavigation. The DTI tractography-based navigation combined with continuous transcortical MEP monitoring and direct subcortical stimulation were performed to localize the subcortical tracts. Resection was continued until one of the three circumstances emerged. First, the margin of the tumor was reached according to the surgeon's observation of the structural navigation. The second, continuous MEP monitoring or direct subcortical stimulation showed a positive result. Third, the patient presented with a deterioration of language or motor function. Then the surgical manipulation was stopped and the intraoperative MRI scan was performed to assess the extent of resection. In this picture, we can see the cortical incision were made avoid those critical areas, and the incision were made longitudinally away from the sulci to preserve the sulcus vessels. The tumor is gradually debulked using the CUSA system, which is set to a tissue selection mode. During resection, subcortical language mapping with a bipolar stimulator was conducted intermittently to ensure no injury was caused to the language pathway. Here we can see a positive point related to the inferior longitudinal fasciculus. This is the workflow of our surgical procedures. Following resection, intraoperative MRI scan was performed to assess the extent of resection. If intraoperative image finds the residual tumor, we will re-inspect the resection cavity and perform the subcortical stimulation to evaluate whether the residual tumor can be removed without damage to the functional structures. If it is resectable, further resection will be conducted by intraoperative real-time image-guided navigation. This is the patient demographics of our 255 cases. This is the pathological diagnosis and patient survival. Based on the 2016 WHO classifications, there are 120 grade 2, 54 grade 3, and 81 grade 4 gliomas. The overall survival data were available for 247 patients. Among them, patients with low-grade glioma had significantly longer survival than patients with high-grade glioma. This is the breakdown of the molecular pathology of 255 insular gliomas. Here we can see IDH1 wild type was more likely to be associated with a tumor affecting only one insular zone, whereas IDH1 mutation showed association with giant insular tumors. In total, 172 patients had an extent of resection more than 90%. Regarding location, extent of resection was highest for anterior zone tumors, with lowest in the giant tumors. In low-grade gliomas, a significantly longer mean overall survival was observed in patients with extent of resection higher than 90% than in patients with extent of resection lower than 90%. Similar in high-grade gliomas, patients with gross total resection had longer median survival than patients with subtotal resection. Regarding tumor location, for low-grade gliomas, giant zone tumor patient had the worst prognosis, but for high-grade gliomas, region involvement was not a significant predictor of survival. This is the neurological deficit. Transient neurological deficit was recorded in 12% of patients and permanent deficit in 15% patients. The main causes of permanent neurological deficits are vascular infarction and functional pathway damage. Because of the time limit, I just want to show one case. This is a 44-year-old man, mainly presented with seizure attack. The physical examination was unremarkable. Preoperative MRI revealed a giant left insular non-enhancing tumor. This is the preoperative DTI fiber tracking for motor pathway. Here we can see the pyramidal tracks. After open epidural, first SSEP was performed to identify central sulcus. Here we can see the N20P20 phase reversal phenomenon, which indicates that the central sulcus the central sulcus is between the electrode 2 and electrode 3. Then direct cortical stimulation mapping was performed to locate the language and motor area. During resection, continuous transcortical MEP was performed to monitor the motor pathway. When the navigation indicated that the resection cavity approached the pyramidal tract, then subcortical stimulation will be performed. For this case, resection was continued until the margin of the tumor was reached according to the surgeon's observation and the navigation. Then intraoperative MRI scan was performed to assess the extent of resection. Here we can see, this is the intraoperative image. We can see here is the residual tumor. So after that, we performed a further resection. In this case, with the help of intraoperative MRI, the extent of resection was increased from 78% to 98%. To achieve more aggressive resection with acceptable neurological morbidity relies on 3 important factors. The first one is intraoperative evaluation of the extent of resection. Intraoperative MR system provides high quality and real-time structure and functional information to assess the extent of resection and accurately locate the residual tumor. Thanks to this system, the extent of resection of insular gliomas have been significantly increased, especially for those low-grade gliomas. The second is the protection of the strong surrounding functional structures. A weak craniotomy with electrostimulation mapping, intraoperative neurophysiological monitoring, and functional neuronavigation is helpful to protect the functional cortex and subcortical structures. The combination of all these techniques above is what we call the intraoperative multi-information guidance. Last but not least is the preservation of important vessels. It requires an ideal approach and skillful surgical manipulation. Which approach shall we choose to expose the insula? Transcortical or transvene? Which one is better? Still remains controversial. It usually depends on 2 aspects: the extension of tumor and the surgeon's proficiency at the approach. Based on our experience, for purely insular gliomas, transvene approach is preferred. For tumor with opercular extension, transcortical approach is recommended. Actually, most of our cases were performed transcortically. And for giant insular tumors, a combined approach is reasonable. Some take-home message. The insular gliomas, especially those giant tumors, are difficult to resect and have always challenged neurosurgeons. Intraoperative multi-information guided surgery tailored for each patient is helpful to achieve a maximal safe resection. An ideal approach and skillful surgical manipulation is also important to avoid permanent neurological deficits. Insular tumor location can predict the extent of resection and consequently the overall survival. This is our team. Thank you for your attention.
Thank you so much. It was excellent lecture. I think maybe Abir Shah, any question to him?
Hello.
Yeah.
That was a fantastic lecture and a fantastic way of managing insular gliomas. And I think you have done a very good job. And I agree with you that both the approaches should be tailored according to the type of the tumor that you're dealing with. In some, you can use Trans-Sylvian approach only when it is just restricted to the insular gyri. And once it is going through the operculum, you can definitely safely use, after your deciding your trajectory, either the transcortical or the Trans-Sylvian approach. I prefer the Trans-Sylvian approach, but there are some cases where, of course, we would like to go transcortical, when especially the operculum is involved. But in general, it's a very good, informative lecture and very nice work. Congratulations.
Okay.
Thanks.
So, you want to say anything to Dr. Abhidashar? No? Is there Dr. Mukasa? Mukasa Sensei, are you with us? Can you make some comment?
It's very good presentation. I'm very impressed. So when you do the awake surgery, do you also use the intraoperative MRI when patients are awake? So is it okay to put the patients into the IMRI? I don't have experience, so I just want
Yes.
to...
Yes. For awake surgery, we can also use intraoperative MRI.
Okay.
Okay. So thank you very much. So no other question. Thank you. So then maybe I switch the MC to Dr. Adi. Adi, please.
Thank you, Professor Kato. So our next speaker should be Professor Yugo Kishida with lecture endoscopic tumor resection through transparent tubular retractor.
I think Kishida is not with us, I think. Kishida Sensei. Next speaker is Abhidashar.
Okay, Professor Abhidashar from Video Region Development and Spread of Gliomas and its Surgical Implications, introducing an alternative concept. Please, Professor Shah, you can continue with your lecture. Professor Abhidashar, are you here? You were here.
Maybe, yeah. Okay. Abhida?
No, I did not. I could not hear. There was some disconnection. Can you repeat that, please? I'm sorry.
Now it's your time for your presentation, so you can continue if you are ready.
Yes, I'm ready. Just give me a minute.
Sure.
Can you see my screen?
Yes. Just go full screen, please.
Yeah. Okay. So I'm going to introduce a little bit of a different concept in the management of these gliomas. Basically, we talk a lot about gliomas, maximal safe resection, on whether we should do awake, whether we should do not awake, whether we should do monitoring, whether we should do intraop MRI, and all those kind of things. But we do not talk much about the origin of the gliomas, about how they spread and what is the genesis of the glioma. So this beautiful organ that is the human brain, before going for glioma surgery, you have to understand both the cortical and the subcortical anatomy very beautifully. It is only then you should do glioma surgery, because it is now not just the cortex that is important, it is also the subcortical pathways, and there is a concept of connectome that is developed, and that makes you realize how a glioma should be operated. So before going into glioma per se, I would like to discuss this paper that we published. This was on the three-dimensional architecture of the white fibers of the brain. So we divided these white fibers into 5 layers. The first horizontal layer was the superficial group, or the short association fibers, this yellow circle here. The second was the middle group, that is this blue circle here, that is the SLF, the AF, the MLF, the ILF, the uncinate, and the IFOF. So the long association fibers. The third group is the deep group, this red circle here, that is in relation to the ventricles. So the fornix, the stria medullaris thalami, the stria terminalis, etc. And the central group, the one that runs in between both the hemispheres and between the vertical group of fibers, is the commissural fibers. So the corpus callosum, the anterior and posterior commissure, the habenular commissure, and the hippocampal commissure. And the last group, that is the vertical group that runs vertically through the hemisphere, is the projection fibers, to the fibers of the internal capsule and the thalamic radiation. So if you look at this image, you can understand that fibers that are medial to this, the long association fibers that are medial to this vertical group of fibers, will remain medial. And fibers that are lateral to this vertical group of fibers will remain lateral. They will not cross. The only fiber system that crosses is the anterior commissure in the depth in front of the internal capsule. So this is the DTI depiction of white fibers. So now with this short background of white fibers, let's go into the gliomas. Basically, gliomas arise from this glial cell, and you can see these various type of glial cells and a lot of function that they perform. Professor Yasser Gill believed that all these gliomas followed embryological and vascular pathways. So basically that they were segmental, they grew all the way towards the ventricle, and they always reached the ventricle. And the shape of a glioma also, according to him, represented a wedge-shaped area, as you would see in an infarct. So this was his concept on the origin and spread of gliomas. More recently, Professor Berger also wrote on neural stem cells and origin of gliomas. Basically, this is what he had to say, that because we don't know the origin of gliomas, because we don't know the origin of glial cells, we are not able to get a rational treatment and finality in treatment of this tumor. Basically, what I have to say is that gliomas arise from neural stem cells. These are multipotent cells, and they are present in the subventricular zone, in the lining of the ventricles, the dentate gyrus, in the hippocampus, and this is important, in the subcortical white matter. So what happens is these neural stem cells receive some kind of genetic mutation, and they de-differentiate and give rise after transformation into either an astrocytoma or an oligodendroglioma. There is another theory that is being propagated by Professor Dufault on diffuse low-grade gliomas, and he has some environmental theory, a molecular theory, and a functional theory that explains the origin of gliomas. Now, based on my understanding, based on our understanding of the white fibers, we have come up with a specific understanding on how these tumors originate and spread. So we say that gliomas are basically confined to a named white matter tract. So it will arise from a named white matter tract. It will destroy that white matter tract, but the adjoining normal tracts will be displaced by the tumor. This concept gives you a different idea into the surgical strategy of these tumors. So looking at this, what we did is we've divided these tumors into two types, localized and diffuse. So this you can see this red circles here. This is a localized group of gliomas that arises from the superficial group or the short arcuate fibers of the gyrus. So this is a localized type of glioma. This is a diffuse type of glioma which arises from the long association fibers. If you see that this tumor spreads along the pathway of the long association fibers. So if this is a cingulum, it is going along the parietal connection of the cingulum and going towards the cortex. Next type of diffuse gliomas are commissural gliomas, and most of these tumors are bilateral. They tend to be bilateral, but another feature is that they are bounded by this vertical group of fibers, which they will not cross. Now I'm going to show you examples of all of this. So this was another paper that we wrote on the radiological evaluation of the anatomical extension of gliomas based on the white fiber tract architecture. So you look at this tumor. This tumor is arising from the superior frontal gyrus. It is actually arising from the short arcuate fibers in the region of the superior frontal gyrus. And it will remain in this area. If it spreads to an adjacent gyrus, it will do so by the short arcuate connections. So the connection that will spread from the superior frontal to the middle frontal gyrus, it will go along that connection. This is a tumor in the region of the inferior temporal gyrus. Again, this is a localized type. It is arising from the short arcuate fibers in this region. This is a tumor in the region of the inferior parietal lobule. arising from the short arcuate fibers in this region. And you can see in this tractography image that all the other fibers are displaced around it or medial to it. There is nothing that is destroyed by this kind of tumor. And there are very important fiber bundles in this tumor, as I will show you further in my presentation. Now, so that was the localized type. Now you see this diffuse glioma. So look at this tumor, look at the radiological image. So you can see it is arising above the corpus callosum and it is going towards the parietal cortex. So this is a tumor that I would call that is arising from the cingulum and going to its parietal connection. If you see the tractography image, you see that the other fibers are displaced laterally, that it will not cross the vertical group of fibers, it will remain medial to this. This understanding gives you the approach. You enter this tumor through an interhemispheric approach. Now look at this tumor. It is a tumor that is involving the IFOF. So it is going in the frontal and it is coming to the temporal. It is an insular tumor which is involving the long association fiber or the IFOF. Looking at this tumor, it is a tumor arising from the uncinate fasciculus. So it has a frontal extension and an anterior temporal extension. As you can see that this is the pathway of the uncinate fasciculus. So this is one type of glioma, and the third type, that is again diffuse, that is arising from the commissural fibers. Now look at this image. If you just project this image, you're going to think that this glioma is multicentric. It is arising from the temporal here, near the temporal horn, in the anterior temporal region, and also involving the corpus callosum. But I would say that it is not multicentric. It is a diffuse tumor that is involving the corpus callosum. To say this, I need to understand the radiations of the corpus callosum. I will show you later in the image how these radiations go. So this tumor is actually involving the dorsal callosal radiation. It is involving the fibers of the tapetum and going towards the temporal horn, and it is involving the anterior ventral callosal radiation, and that is how it is reaching in this region. So the spread of gliomas is completely based on understanding of white fibers. Going further, Professor Goel devised this strategy for surgical excision of low-grade tumors that was arising from the short arcuate fibers, and we call it an en-masse tumor resection. So let me give you an example of this. This is a tumor that is arising from the supplementary motor area. As you know that the supplementary motor area lies in this region anterior to the precentral gyrus in the most posterior and middle part of the superior frontal gyrus. So if you see this DTI, the internal capsule is pushed posteriorly by the tumor. It is involving the short arcuate fibers and it is going right above here in front of above the corpus callosum. So what is the surgical strategy? Now, if you see this video, of course, sometimes you need to perform monitoring. You can perform monitoring. You can do it awake. You can do it non-awake. You can do it however you please. But this is the surgical strategy that we are using. So the monitoring here was done to identify the central sulcus. But essentially, this is the strategy. So with practice, you will be able to identify this plane of tumor. You will be able to identify between normal and abnormal just by a visual impression. Once the visual impression is confirmed, you will also be able to confirm this by the feel of the tumor as you are dissecting around the tumor. So basically what we are saying is for tumors that are arising in the short arcuate fibers or tumors that are localized in this region, you can perform an en-masse surgical resection by forming a pseudo plane around the tumor. So you can see in this video, a complete plane is being formed around the tumor and the whole tumor will be resected en masse. Again, a benefit of this technique is that there are no blood vessels that come in the way and normal vessels are generally preserved and you do not need to coagulate anything outside the tumor, thus avoiding any ischemic or vascular injury. So going further, so this is the resection of the tumor in an en masse fashion. You can see that this vessel here is being preserved. You have to learn this art of dissecting the tumor. It comes with practice and you can easily do it. And you can do it very nicely without too much worry. I know for sure that I'm not damaging any normal structure in this surgical resection. So this is at the end of the resection. And that I know it because I know my anatomy very well. And I know that I'm able to do a good job. So you see this patient, this is the post-operative resection cavity. You can see the tumor resection and you can see that the transcranial MEPs have completely been maintained. There's another tumor that is just abutting the precentral gyrus. Again, you can see that the tracks are displaced posteriorly and laterally. and an en masse resection was performed. I'm not going to go into the whole video, just to show you a few steps how we identify it. We use ultrasound, intraoperative ultrasound, to identify the margins of the tumor after confirming with a visual impression, and that gives us a little more aid while performing the tumor resection. So here you can see an en masse resection being performed, and the whole tumor is removed as a mass, as you can see here. And then at the end of the resection in the cavity, you will see the normal white fibers that are preserved. So you see this, these are the normal white fibers. And this thing here is actually the motor strip that has completely been preserved. And this is the patient in the immediate post-operative period after 10 days at the time of suture removal. And you can see that there is no deficit. And this is the resection cavity. Now, this is another tumor. I wanted to show you ultrasound images. So you see this is a pre-operative ultrasound of this tumor. Again, it is just in front of the precentral gyrus on the left side, abutting the inferior frontal gyrus on this side. It is essentially arising from the short arcuate fibers of the middle frontal gyrus, but I have performed this about a month back without any monitoring, without any awake surgery. I have identified this tumor by ultrasound. This is the resection cavity in the post-operative period. You can see that there is no tumor left. This is the post-operative MRI, immediate post-operative MRI. This is the tumor specimen, and this patient did very well without any motor or speech deficit. This is again another tumor that is just in the supplementary motor area, and you can see the post-operative resection. Again, another tumor removed by the en masse strategy, and you can see the post-operative resection. So these are just tractography images that we build while performing the surgery. You don't need to do this every time. As you gain experience in your anatomy, it is there in your mind. The whole tractography atlas will be in your mind, that when you're operating like this, which tract will come in the way. But if at all you're using DTI, one tip is that do not ask the radiologist to make your DTI images. You go yourself and draw the images, because if you know the anatomy, then only you will be able to draw the tracks around the tumor, and then only you will be able to identify the tumor. The radiologist will not be able to give you this information, and I do these myself whenever I use tractography. So here you can see that I've constructed all the tracks, the arcuate, the IFOF, the optic radiation, the internal capsule, and this is the tumor. So basically, this is again another tumor in the region of the superior parietal lobule. As you can see here, all the tracks have been displaced either anteriorly or inferiorly or laterally, and an en masse resection was performed. This is the immediate post-operative scan. Another tumor with a post-operative resection cavity. As you can see, an en masse resection was performed. Now coming to this region, the inferior parietal lobule. So there are multiple tracks in this region. So the IFOF, the anterior commissure, the fibers of the tapetum, the fibers of the arcuate fasciculus, the fibers of the middle longitudinal fasciculus, and the optic radiation, they all converge in this region, the temporoparietal occipital junction. And you cannot, on the right side or the left side, you cannot damage any fiber in this region, because it will cause a deficit. Whether it is a manifest deficit or a non-manifest deficit, you cannot cause a damage here. But if you again understand that this is a tumor that is arising from the short arcuate fibers, it is just going to displace the long association fibers, then you can go in and perform this radical resection, and the patient does well without a problem. This is again a tumor in the occipital lobe, and you can see the resection. This is the preoperative, intraoperative ultrasound image, and this is the post-operative, intraoperative post-op after the resection. Coming to the insula, today we had a beautiful lecture on insular gliomas. Once you open the curtains of the insula, you see the anatomy of the insula beautifully. So the short gyri, the long gyri, separated by the central sulcus, which is in the same direction as the central sulcus of the cerebral hemisphere. This is just an image to show the relation of the insula to the various parts of the ventricle. And now going into the fibers of the insula. So we saw some beautiful DTI images by a previous speaker. Now let me show you the anatomical counterparts. So the operculum have been removed here. These are short arcuate fibers. This is the SLF2 and the SLF3. These are fibers of the external capsule as they go on to join the corona radiata. This one is the arcuate fasciculus as it is running down to the temporal lobe. In this region, this is the IFOF that is running from the frontal and the temporal, and this is the uncinate that is running from the frontal and the temporal. So once I lift this arcuate fasciculus, you see that this IFOF runs in towards the occipital region. Just beneath the IFOF will be some fibers of the anterior commissure and fibers of the optic radiation. These are fibers of the uncinate. This fiber bundle that you see below is fibers of the ILF, and this is the region of the insula. This is the putamen that has been partly removed. And after removing all the gray matter of the insula, this is the entire extent of the internal capsule, the anterior limb, the genu, the posterior limb, the sublentiform, and the retrolentiform part of the internal capsule. So these are again high definition tractography images that show you the tracks that are relevant to insular surgery. Now let's go to the strategy. So if you see this tumor, it is arising from the operculum, the pars opercularis of the left side of the cerebral hemisphere. So according to this, according to what my understanding is, the fibers are pushed medially by the tumor. This is neuronavigation, which we use sometimes, not regularly. We used to use it regularly, but now the need has decreased. So we plan the tumor in this region. This patient did not agree for an awake surgery. He was not at all cooperative. As you know from the location that I am in the so-called Broca's area, and this is the ventral premotor area just in front of the precentral gyrus, and stimulation in this area will cause speech arrest. I'm going to be operating in this area, and we operated this tumor just based on anatomical understanding. The patient again was not awake. However, we tried to do the patient awake, but he was just not cooperative. So we had to perform under anesthesia. And you can see that using the same philosophy, using the same surgical concepts, we have gone in and removed this tumor in an en masse fashion. As you can see, all the vessels that were going through the tumor were preserved. Even this vessel that was going through this arachnoid layer has been preserved. You can see the normal arcuate fibers in the depth of the resection cavity. And this is at the end of resection. And now I will show you the patient on day 1 after surgery. And you can see his speech. You will not understand it, but you can hear him speaking normally. Little bit of dysarthria, which improved in the next 2-3 days. But this is his speech. You can hear him very clearly. So, and this was the post-operative resection. You can see that the tumor has been removed and all the tracks have been completely maintained. And this is the post-operative resection cavity. So coming back to insular tumors, this was operated again using a Trans-Sylvian approach. And this is the post-operative resection. Again, tumor that was some pre-operative and post-operative images. For the young friends, when I was younger, maybe 7-8 years back, I once was doing an insular glioma and I had some trouble identifying a long perforating vessel. I was not able to identify whether the vessel is going on to supply the normal parenchyma. So I just used this intraop while doing the surgery. I just thought I will use this in ICG, and you can see that I separated this vessel by identifying it by the ICG, by realizing that it is going on this vessel, that it is going on to supply the normal parenchyma, and that I had to save this vessel. So you can see this vessel that was going through this, and this is the tumor. So ultimately I dissected the tumor from this vessel and saved it complete. It was a very firm and rubbery tumor, which had some difficulty during the dissection, but ultimately I managed. And you can see that the vessel was completely preserved and the patient also did well following the surgery. This is another tumor that was resected quite radically. Some tumor in this region was left behind. This is again tumor that is arising from the uncinate, and you can see that a radical resection has been performed. So just these are just some pre-operative and post-operative images for the want of time, but we also use the same surgical strategy for high-grade gliomas. So these are high-grade gliomas involving the region of the insula, and you can see the post-operative resection that I have performed, and you can see how radically the tumor has been removed. This is again another tumor that is arising from the involving the uncinate fasciculus going in the frontal and the temporal region, and using this strategy and understanding the anatomy of the uncinate fasciculus, I have removed this tumor. This is a tumor that is arising from the SLF, the medial part of the SLF. You see in this MRI image, this is the part of the tumor. And this is the anatomy of the tract as it is going through the SLF. And this is the post-operative resection cavity. As you can see, a radical resection was performed. Coming shortly to the limbic system, this is another important area. Anatomy has to be understood because limbic and paralimbic tumors, like insular tumors, are very common, low-grade tumors. So this is just a dissection of the Papez circuit. So this is the hippocampus, the fimbria, the fornix, the body of the fornix, columns of the fornix, the mammillary body, the mammillothalamic tract, the anterior nucleus of the thalamus, the anterior thalamic radiations, and the cingulum coming back here and ending in the hippocampus, forming the whole Pappage circuit. And we published it in 2011. And this was the whole Pappage circuit that we dissected outside the hemisphere. And this kind of dissection has never been done before. And I'm not sure if it has been done now. And this is a very highly cited paper, one of my favorite papers. How it helps me? It helps me because now I know that this tumor is part of the cingulum. I know that I have to approach it in an interhemispheric fashion. And I know that I will not damage any of the other association fibers. So going in, these are the tractography images that were reconstructed to show how the tracks are spread at the margins of the tumor and are not involved. This is again a tumor from the isthmus of the cingulum. So this is the part of the cingulum. Why I don't call it a corpus callosal tumor is because it is not going bilaterally. It is remaining confined to this region. And I like to call it a tumor arising from the isthmus of the cingulum. These are tractography images. This was, we use neuronavigation for this, and you can see the post-operative resection that has been performed. A tumor of the parahippocampal region. Again, if you realize that all these fiber tracks are pushed superiorly by this tumor. So the safest route is to come from here. Either you come from the middle or the inferior temporal gyrus and you enter it, and this is the beautiful radical resection that you can perform. So while approaching medial temporal region, you have to remember that there are fibers of the IFOF and the optic radiations that are in close relation to the temporal horn. So again, by our dissections, we have come to know that there is a part in the anterior aspect of the temporal horn that does not have any fibers of the IFOF or the optic radiation. The Mayer's loop actually turns and goes like this in the lateral part of the temporal horn. So you can easily enter it from here. So I'll just go quickly. And this approach to the middle temporal gyrus was devised by Professor Goel. And you can see that using this, we are able to perform an en bloc resection. So this is just a paper that we've published. And you can see that this is the trajectory. And this is the way we enter without damaging any fiber bundles. Just to show you a free preoperative and postoperative examples. This is a tumor that I've resected. This is again another tumor of the parahippocampal region that has been resected beautifully. And lastly, coming to corpus callosal tumors, just a few examples. So as I said, that these are the corpus callosal radiations. So if you see this purple one, these are dorsal callosal radiation. If you see the yellow, this is forceps major or the posterior callosal radiation. And this is forceps minor or the anterior callosal radiation. These are the tapetum and the anterior ventral callosal radiation. So now you know how that tumor spread. It has gone from here to here and to here. So that is how I call it a corpus callosal tumor. And this is our paper on the subject. And this is just an example showing the corpus callosal tumor identified by understanding of anatomy. And this is the post-operative resection. Again, another tumor of the forceps minor that I did recently. And you can see the post-operative resection cavity. Radical resection was performed. Lastly, this tumor of the splenium on the left side, and still a radical resection I was able to perform, understanding the anatomy. So to end my lecture, basically anatomy is the key. You have adjuncts like navigation, you have adjuncts like sonography, you have adjuncts like monitoring. But if you don't understand the anatomy of these white fibers, you will not be able to perform a good glioma surgery. Thank you very much for this invitation. And thank you, Professor Kato, for allowing me this opportunity to present in this webinar. Thank you.
Thank you, Professor Shah, for this wonderful, outstanding lecture and very nice videos. I really like your technique. And I will have a question. Do you use the same suction dissection method which we have seen in a high-grade, low-grade glioma, even in deep region? Do you say we always use this same technique, or you maybe change it according to situation? Maybe you can share your experience with us.
So when the tumor is little superficial, you have seen the technique. I've shown you some videos. For high-grade gliomas, sometimes the tumor bulges out. So what you can do is you rapidly go in and remove a little bit of the central bulk of the tumor so the brain relaxes. But after that is done, you can still form this beautiful plane around the tumor and then form an en masse resection. For deeper tumors, like that I didn't show you today for want of time, but there are tumors in the region of the caudate head that once you reach the tumor, then you can form this plane. In the region of the insula, I don't recommend this technique because there are many vessels that are present in this region. So you of course cannot go all the way. But what you can do is between the vessels, between the M2 and the M3 branches, you can again perform a localized resection by using this technique. And yes, we use the same suction instrument. It's actually a suction and a dissector combined. So it helps us, it gives you a feel of the tumor, and it also helps you remove the tumor.
Actually, you just answered my second question about insular glioma. It was my second question. Thank you so much. Are there any other questions from the audience?
Adi, so maybe just I want to ask Dr. Mukasa, because he's expert of the glioma. Dr. Mukasa, do you think, because Abida Shah showed us the tumor just removal as a mass? So do you have such an experience? How do you remove the tumor, glioma tumor?
Yes, first I'd like to thank to show us the beautiful video and surgical technique. So I wonder, I agree that your the concept that the glioma preferentially grow along the white matter tract, but there are also, but there are many exceptional cases. That case is very difficult. So, the glioma located on the eloquent and or the invaded into the eloquent area, it's very difficult to perform your technique. So in such case, how do you perform the surgery? That is my question.
So eloquent area, for suppose if you say in close vicinity to just in front of the precentral gyrus or something like that. First of all, pure motor tumors, pure tumors arising from the precentral gyrus are rare. They normally just abut or they're in close proximity to it. So initially, when we were doing this technique, we used monitoring. We used a lot of monitoring to identify the central sulcus and, to see how it is. But as we started performing this surgery, we realized that we are able to perform this technique without causing a deficit if you remain within that understanding of your tumor, where the tumor is, and don't go beyond it. So that way we are avoiding the need for monitoring. Of course, I need long-term results to show how much of this kind of radical resection is, how many overall survival, how much it is giving. We already have about 4 or 5 years, but I'm waiting for a longer survival, and then we will be able to give a better answer to this question. But yes, we are using a similar technique even for eloquent areas, because we have a lot of patients who do not actually cooperate for awake. They are not very well educated. They come from the interiors of our country, and it is difficult to, get an awake surgery on this. There are some, of course, that cooperate, but some don't. So we have to come up with some strategy to deal with this kind of tumors.
Thank you.
Okay, thank you. Are there any other questions? If no, there is our next speaker, Dr. Arion Musabeliu from Albania. Please, you can continue with your lecture.
Thank you very much, Adi. I must say I'm short of words every time I'm following any lectures from Abida. It's a mesmerizing work of anatomy and outstanding surgical techniques. Thank you, Abida. I have included you in my talk, so please don't leave. Stay here. Okay, let's get going. Wonderful. There is nothing that I would have in any relation to disclosure, but related to the topic that I'm highly interested in involved is metastasis and then cancer biology of brain metastasis. So let's, just to make sure that you see a full screen, nothing but that. Is that okay on your end?
It's fine.
That's perfect. Good. I'll try to keep my objectives related to questions that relate to what we don't know yet on the pathology of brain metastasis, and provide additional information before ending to such end questions. Well, I was happy to find out that I would be joining you guys today. So I put together a few images of what it was when it all started. I'm the guy who took the picture here, so I'm not in the picture itself. Happy that you would be here in 2017. That's us in Japan, and then if Ibrahim is still somewhere here, a guy that knew how to bring friends together, and that's Salzburg. Ibrahim, an international, world-renowned guy, well ahead of time. So that's where I am now, and all I have to present, I dedicate to some work that I've been conducting to the University of Toronto. It has been home for me in the recent years. To the point of brain metastasis, I'll start with some statistics. It is the most common tumor we face in our everyday challenges when we see patients with cancer problems in neurosurgery. Most of the data related here in my presentations come from US or North America, not necessarily because I choose to, but unfortunately there are not many epidemiological studies conducted in the field of brain metastasis that have substantial information for us to deduct. Just to know that about 150,000 new cases annually are diagnosed in US, and that's about the same percentage that we would see in other countries. When it comes to frequency, the most frequent primaries are lung and breast. Usually that's in female patients, but then when it comes to male and beyond the 5th decade of life, that's lung and melanoma that take over. These are some statistics I have collected from Sweden and Netherlands. You would see the differences. The reason I choose these two countries is because they have substantial and meaningful data that have been collected throughout the years. The variances remain, but the numbers are different. If you see, it's about 2 times more the incidence in Sweden. I don't see any reasons why, but the cases are. The frequency of the primaries remain the same. It's lung, breast, and colorectal. But then for men, it's lung and melanoma and colorectal. When it comes to regional differences, that I mean by geographical differences, and the incidence varies from Eastern Hemisphere, and there are some data from China coming all the way to Western Europe and here in North America. And I'm always curious to question myself, why is that the case that there is variability in incidence in between the countries that I mentioned, but in general, when we discuss with colleagues. And I have found few relevant papers that I wanted to put together, and the reason there are some variability in incidence and prevalence, not necessarily only in metastasis, but in most of other diseases that we face and challenge our knowledge in medicine, is because there are changes, genomic windows of change in between different ethnic groups. These have been conducted throughout the years, but 2 recent papers published in 2020 and 2021 just confirm that those loci of genomic variability in between ethnic groups determine not only how we are affected, but the outcome of most of the diseases that affect humans are dependent on those changes. When it comes to my country, to Canada, not until recently, we had a database of the incidence of brain metastasis among cancer patients. In 2022, colleagues published a list of the primaries that would affect brain, and it turned out that that's the statistical findings. It's lung and GI, followed by kidney, the first 3 primaries, and then skin melanoma follows as the 4th one. Now, this is a data from US. When it comes to having a brain metastasis finding along with the primary at the time of diagnosis, you would see that it is lung and melanoma that take the first 2 places, but the lifetime occurrences of brain metastasis still remains the same. Primaries are lung and melanoma. So we have very commonly heard about lung to being the primary, the most common primary. So is the breast, but skin cancer, without any doubt, is #1 cancer worldwide. Is there any metastasis disease in pediatrics? Yes, there are cases, not to the frequency of the adults, are rare. What I find not in my research work, but when I have to cooperate and work with other colleagues, I find that there are distinctive differences in between adults and pediatrics. What these are that in most cases, pediatric tumors are standalone pathologies. They have both genetic and epigenetic mechanisms that differ from those in the adults. The risk factors and the exposure to these risk factors differs in the pediatric population compared to the adults. The way they spread and the mechanisms implicated for the metastasis process quietly differ so in between pediatric and adult population. And when it comes to the primaries, so huge differences. It's germ cell tumors and sarcomas that take over the first 2 places, in difference with the adult population, where sarcomas do extensively grow and are aggressive tumors in the adult population, but not necessarily in the top 5 primaries that metastasize to the brain. The epidemiology data that was conducted in Detroit in 2004 was still a reference point to today that shows us the changes in frequency as we age. And we find out that in between the 3rd to the 4th decade of life, it's breast and lung that take over, the 2 primary sources of brain metastasis. But then moving on toward the 5th decade of life is melanoma, and usually the skin cancer that takes over to be the primary source of brain metastasis. So what does that mean when we talk about age group differences? Has it anything to do with the extent of the exposure to the risk factors? Or has anything to do with the hijacking of genomic or epigenetic mechanisms that we were not aware before or to the day that do make melanoma and overall skin cancer to become the primary source of brain metastasis? When it comes to skin cancer epidemiology, 3 are the common pathological sources. But I would like to point melanoma. The reason is that is very simple. Basal cell carcinoma, squamous cell carcinoma, more often than not are diagnosed clinically before the time of metastasis. Not necessarily to the brain, but even local metastasis is rare in occurrence compared with melanoma. And on the other hand, I find melanoma not only pathologically, but embryologically deriving very different from the 2 other topics. When it comes to melanoma on its own, if we were to break down some numbers, it's about 85,000 people that are diagnosed with melanoma, and that's data from US. And of those, about 8,000 will die from the disease. It is unfortunate unless you diagnose it early in the disease process. But these are the patients that have been diagnosed on stage 3 and beyond. And 2/3 of these patients are of older age. My apologies, no longer considered that of older age are average 55 years or older, no longer considered older in US. When it comes to skin cancer, the reason I stop here, the skin cancer and the epidemiology data still comes from US or in North America. Melanoma has the highest mortality as the disease process progresses. It is the tumor the most frequently metastasizes to brain. So it is important to spend a moment and use it not only for examples and an analogy, but focus the research work that has been done in melanoma on its own. Now, these are some gross images coming out of the most common skin cancers. But what stands out for the skin on its own as an organ is part of the ectoderm when it comes to embryological development. And I take note of the development because in my research work and findings, not only from my work, but that of colleagues, we do believe that cancer in its own does not develop new genomic highways to progress as a disease process. It is rather what we don't know, we find often in cancer that is related in early days, what is normal development. The problem with cancer is either the cancer mutates something that is a suppressor, or cancer mutates something that is a pressor to an oncogen. When it comes to melanoma and skin on its own, it's an extraperitoneal organ. It stands out of cavities, not necessarily required to bypass heart, lung, or liver, which are sometimes substations for other primaries. So when it comes to organ system then versus the cell of origin, in the research of cancer biology, we read data, we do statistical work, we talk about lung, we talk about breast, we talk about kidney. But when we talk about melanoma, we must bring up front what melanoma on its own is. It is part of the skin cancer, but is a cell originating embryologically so much different from all other cancers we study. But we group it together with organ systems rather than studying the cell of the origin. Is it a way for us to not be able to succeed in the research, considering as a bulk, or we should focus on the cell of origin rather than the organ itself to find avenues that trick or tweak the genomics of the cancer itself for us to target those when it comes to treatment modalities? So when it comes to melanoma on its own, it has four main cancer, most common types. It is important to mention that these four types are not necessarily spread the same way, and the frequency is different throughout Eastern to that Western hemisphere. So is the change between southern and northern parts of the globe. Now, if we were to bring down numbers, most of those metastases coming from melanoma present neurologically with clinical symptoms, either for focal neurological deficits, which in most cases and related with melanoma are due to hemorrhagic or larger lesions or cystic lesions. Most of these lesions related to a primary melanoma are supratentorial. When it comes to imaging, about 1/3 of the lesions are single metastasis, and then the two other parts of the third within the 100 divide into either in between 1 to 2 or more than 2 metastases. So is it fair to say that melanoma requires more attention? I should say yes. It's a challenging tumor, not only the primary, but as it spreads throughout other parts of the body, not necessarily the brain, it is challenging to treat. Even if we have removed the primary itself, median survival in most cases is 4 months. And I highlighted in red why then ipilimumab, which is a monoclonal antibody introduced in 2012 for use in North America. What has been the change in overall survival? Not necessarily much, because the avenues we need to target are so many that with only one drug or many to follow in the category of monoclonal antibodies haven't been of very much help. When it comes to melanoma on its own, we do find about 22 or more than that of cases to be of an unidentified primary. And it happens not only with melanoma, but melanoma stands to be the most frequent of those primaries, but could not identify a primary lesion. What does that mean? when it comes to research work and work conducted in the lab, then the question stands, if we cannot identify a tumor such big or small in size, then research-wise, what should be the smallest size of the primary and its clonal composition before we can identify a tumor? What I mean by the size is we cannot find a primary and we are lost in the battle to save our patient. What it means to clonal composition of metastasis is that every cancer, when it comes to the point of malignant tumors, is a composition of many clonal cells. I wanted to bring this imaging of the stages of melanoma to the attention of every one of us here, because in literature has been published, and it's still a point of reference, that stage 2 melanoma diagnosed is curable. Unfortunately, in recent years, I've seen not only patients, but cases where that's not stands true, and I'll explain why. Frequently, we see that stages 2, 3, and 4 account for 25% of all cases in melanoma brain metastasis. I pointed earlier that if we are to consider stage 2 diagnosis clinically, it should be considered curable. That's not the case. And I do not want to relate here if that's a BRAF mutant positive or it's a wild type. When it comes to extracranial metastasis, 2 to 3 of those metastases in 60% of cases and of our patients are present at the time of diagnosis. So going back to embryological studies, melanocytes derive from a same bulk within the neural crest development. They use mechanisms of normal development to travel just along any skin segments that has to form our body, and it travels with the limbs, it travels with the torso, it travels with the lower part of the body, so it moves along with the vessels, with the nerves. Here there is nothing new, but when it comes to melanoma, the research shows that it hijacks the existing genes and these mechanisms that we haven't understood yet, that belong to nerval development, but makes use to the pathology of cancer to spread and not only invade locally. Now, we are aware, or at least what we have been told by a fundamental research work published earlier, that tumor spreads in different ways. We know that it has been published out there, although these are done in animal models, and I want to point that it's animal models, not humans. The tumors use blood to spread. Okay, fine. Tumors cross and move diagonally into vicinity organs, and they use lymph to move into lymph nodes. And from there on, it's a different bulk game, because then incorporating the interaction with the immune system within a lymph node, tumor itself is no longer what it belongs to be, a primary. But here it comes, what head and neck cancers show us, although rarely, rare as a primary tumor compared with lung or breast or colorectal or skin cancer itself, they very rarely metastasize to the brain. Is this the paradox of the distance, which tells us that there is more than just what we know about the mechanisms of the spread of metastasis? Now, when it comes to skin cancer, and I want to bring to the attention of all of us that if we had a head and neck cancer, irrelevant of the organ of origin, it might be a muscle or adipose tissue of the head and neck, melanoma itself within the skin in vicinity to head and neck will metastasize to brain earlier than any other organ, irrelevant of the frequency of the primary. What does that matter? From that point on, the stage is irrelevant. If you were to cut a stage 2 melanoma, diagnosed clinically and then pathology, I would recommend all of us to have an MRI done to the patient if the melanoma of stage 2 or beyond has been diagnosed to the region of head and neck. But that's not the case with head and neck cancers. Different topics, different cancers, different research work done. And that's the paradox of the distance which led us, that's the research work we are conducting. There are more mechanisms that what we know and how we know that cancer cells move or spread from their primary to the brain, at least in our case. Now, this is what we know in general, and these are the primary tumors or most common primaries, not necessarily all. From these pictures are missing sarcomas, a very aggressive tumor, but they do not often metastasize to the brain. So this is the commonality of what we know in statistics. So when it comes to the tumor spread mechanisms, we have heard about the spread through lymph nodes. We have heard about the spread through blood. And now I mentioned earlier a mechanism that we are questioning, which is neither of those, neither the lymph, neither the blood, but something that we are trying to figure out what that is. And what is that mechanism? This is what we are working on when it comes to those changes that occur. So is this pertinent only to melanoma, or these mechanisms can be applied? The new mechanism that we are hypothesizing can be applied to other cancers, to other primaries. So we have come out with some ideas, not necessarily going to produce results, but you have to start with some hypotheses in the research of cancer. And these are what we believe to be the trajectories that we will be studying in the future. The primary, what does the primary really use to move around? I mentioned earlier that all cancers, all primary tumors are a composite of different clonal stem cells, supporting cells, not necessarily malignant stem cells. And hierarchy of those cells and their interaction makes what a cancer is. But in reality, the fact is that for a tumor to exist when it comes to the primary, the interaction in between all these clonal cells should be present for the cancer to grow, to progress, and to give us what we know to be the cancer. Now, if the cancer has to move, and I'm trying to debunk some of the mechanisms that we know, if the cancer has to move via blood, for a cancer to survive in blood and for a cancer to settle in any organ you mentioned, including brain, several mechanism has to be combined together, and that's the presence on not only one cell type coming from the cancer, but several of those clonal stem cells or not coming from the primary should be present in the blood, circulating or not. Now, are they part of any genomic material circulating? I don't think that's enough to remove a primary and settle a tumor somewhere else. It requires more than that. What I mean by that is that there is so much space within any blood vessel. From work conducted into identifying what is the incidence or cancer-associated thrombosis in cancer patients with primary tumors, and I mean only not those related to the stagnation of the blood, which is usually a moribund patient, but those patients who are active, have a primary that has already been diagnosed. Yes, there is an increase in a cancer-associated thrombosis with a primary, but that's not a significant increase. What I want to point out by that is that it cannot necessarily be possible for the cancer cells to move freely in the blood, which yes, they do, and then settle somewhere, which in this case is brain, and then produce a metastasis. There is more to that. There are more mechanisms interactions and communications in between the primary and the metastasis that exist well ahead of time of the diagnosis. I wanted to bring something that I've learned from nature. And when it comes to nature, this is pure biology. There is very fundamental research that has been conducted in insects' life. And if you see these clades, these hierarchies of work, these how would compare the life of a primary. The life of a primary, not necessarily to the extent of that of an insect, but it has a queen, which is the cancer stem cell, and it has cooperating hierarchy of clonal cells that make the bulk and have the primary work. Now, for a primary to be called cancer, all these have to be together. For the metastasis as well, all these have to be together. And how can we communicate in between the primary and the metastasis? That's the key that we are still trying to understand. And when I say we, not necessarily the research that we are conducting, but even colleagues throughout the world still trying to figure out how that works. So ants surprisingly have these means of communication. They have hierarchy, just like the tumors. And I've been trying to think if coming with these simple models, not to make comparisons that are fundamental in cancer research, but trying to understand what is in a primary that is different in blood, and then what is in blood that is different from the metastasis. There should be communication for sure. This is, I guess, one of the most wonderful papers that I would kindly suggest any one of us to read. In 1810, Mr. Hauschip, a surgeon in Britain, came up with this fantastic idea of a case of metastasis. Is it a case of metastasis, which comes from Greek, or is it translation of a disease action? So back then, someone had a thoughtful meaning of what the process is on its own. I wanted to put a second paper in my presentation, not necessarily to the extent of the importance of Dr. Hauschip, a surgeon, but to make it a point that this is one of the most quoted papers in cancer biology of metastasis. That's Dr. Page, the distribution of metastasis, which is the seed and soil. Yes, there has been research in animal models to show that there is some significant reason to believe that metastasis is a process that whereby metastatic cells coming from the primary do navigate in other parts of the body, where is soil for the seed to grow. But that's not necessarily the case, and I'll show why we have been wondering that, but the truth is different. So a cancer needs to move around, right? A cancer needs to invade. A cancer needs to transform itself. And that was what Dr. Elizabeth Hay in Harvard, she is a biology scientist, in 1986 came with this finding of the epithelial to mesenchymal transformation of cells in normal development. This has nothing to do with cancer so far. This is just normal development. And I want to point out that more often than not, what we learn from the cancer biology of tumors and metastasis, we find out that somehow has been hijacked from normal development of humans. In 1989, she concluded in the theory that this is a normal process whereby this transition allows the body, back then she was studying chicken embryos, to develop, to transform. And that's how the embryo grows, starting from a sphere and making all the way to the embryo, which is the standard as we know. And this is how these cells normally move. But that's not the case with melanoma. Not necessarily required for the melanoma cancer to have this transformation occurring in the primary before a metastasis occurs. So it brings me to the point, and then I'll put together the work of Dr. Page back then in the 19th century, that the seed and soil is not always necessary to be the case, because it is part of the mechanisms of the primary cancer to modify biochemical processes that we know to be normal for those to live under very limited resources. And those resources will be taken from the surrounding normal tissue. But that's a hypothesis that sometimes have been accepted like that, but in my research experience, it's time to drop it down. So is the case with the invasion, not necessarily all primaries, and that includes melanoma, would require that transformation. The theory of epithelial to mesenchymal transformation of a primary to move and invade. So when it comes to that work in 2019, two researchers from Alabama University, Dr. Doug Hurst and Danny Welch, well known in the field of cancer biology of metastasis, wanted to put together this work of what are the hallmarks of metastasis. And the reason that I brought these images is their way of spread. I've tried to understand, and if that makes sense, their work has always been conducted in animal models. In my research work, I try to put models that come or stay away of animal models, because for a very simple reason that I would show after, not necessarily to be true when we extrapolate these data in humans. Now, we pointed out that hallmarks of cancer speak of cancer to be cancer. But here is not only one case, I can show you abundant number of cases, which in research and in the world of science is one case is more than enough to debunk a theory. This is a brain metastasis of atrial myxoma. This is a benign tumor of the heart. It's a case report. Do not worry about it. The data shows that there are more than just case reports. So far we have thought, or what we know is that the cancer biology of the malignant tumors is such that those are the guys, the bad actors who can metastasize. The reality is not. Under the influence of heightened interleukin-6, benign tumors can metastasize too, so well in the brain. So do we have to change what we know about the definition of cancer on its own and the definition of the metastasis as a disease process? And then I go back to that early paper, and to my understanding, if I am to be correct with the history, 1810 paper of Dr. Harthow is the first paper to be published in metastasis history. I guess it has been time for us. The reason I point this page is this is the National Cancer Institute, the #1 body to fund the cancer research in North America. So we still are to this, and I just quote the first part of the sentence, the spread of a cancer cell from the place where they first form to another part of the body. What is metastasis? That's no longer correct. It's no longer a cancer cell. It can be any cancer cell under limited influence of certain inducers that make that cells either from a malignant or a benign tumor to move either via blood or invasion. And that's what leads us to believe that even the brain metastasis definition is no longer correct, because it starts with the cancer, not a tumor. Do they know better? Of course they know better. Am I any smarter than them? No. This is what I've been finding throughout the research work that I've been conducting. I was curious enough to question those first to myself and then find out that maybe we are not correct with some of those definitions. And when it comes to definitions, it comes because the mechanisms of metastasis is no longer what we think to be. Where do we stand with diagnosis? Here is the reference of melanoma brain metastasis. This is a diagram I use often, and I quote this for cautionary use by colleagues. It hasn't been published, but it has been very useful to me. Do I know the primary or not? That's how I move. If we know the primary, then we try to find out where the primary is, in which part of the body. Does it make sense? Yes, for melanoma, it makes sense. It is very important in skin cancer to know where the primary is coming. And then we move on, we move forward with the techniques that we can perform. Do we have to do cytoreduction by removing the primary, or removal of primary is not necessarily going to help us? Still, we have to perform the surgery. How many metastases do we have in the brain? Or are these, if we have data enough, and I mean, if we have data enough, not every colleague throughout the world can conduct molecular studies to find if that's a BRF mutant or a wild type. So is it or not a case to conduct surgery, or do we have the means to treat with immunotherapy? When it comes to diagnosis and differential, I would not stop, but there are well-advanced techniques that can be used not only in advanced countries and regions like North America, but even in others with limited resources. When it comes to diagnosis, yes, pathology remains the gold standard for most of us. And I mean that by most of us, because even in North America, not every neurosurgical institution has the means to conduct molecular studies. When it comes to prediction, this is a point of a very great importance. We know we have a primary, it's lung. We know we have a primary, it's kidney. We know we have a primary, it's breast. But can we predict when this, if this tumor is going to spread? Then I'll come back to the staging for the very simple reason. Yes, somehow there is a reason for us to believe that a stage 2 melanoma, and I want to point out melanoma, and now I can talk about lung cancer as well, or breast cancer types, but this has been my focus, of head and neck skin regions. I would argue that it is important to remove the primary and then do an MRI of the brain and warn the patient that the risk exists, even though we remove the primary, for a tumor to occur later, and that's going to be the metastasis. Now, when it comes to more caudal primaries, I'm going to bring the example of a colorectal cancer. Even within colorectal, if we were to study right part of the colon, which is the ascending colon, the ileocecal valve, and the left part of the colon, substantial differences exist. And I mean substantial by 10% variability in between right and left part. When it comes to colon, where one should bear in mind, and I want to bring some anatomy here, that colon in part is intraperitoneal and extraperitoneal. What I mean by that is that those exert filter options in between the primary and other organs. But if we come to the point where we see a patient with a colorectal cancer coming from the ascending colon, the chances for metastasis to the brain, even if there is no metastasis to the liver, are higher for a lesion on that region compared to the lesion that come from the left, which is the descending colon. So do we need to reiterate that dissemination of primary cancer cells via blood is no longer a mechanism that we can consider viable? Mechanisms other than that should exist, and that's what we want to find out, or at least what we are investigating. Can we predict metastasis? And in case of melanoma, I think we can, not to a certain, not to a highest extent possible, but we do tell our patients this. A melanoma located in skin parts of head and neck has a high propensity for brain metastasis. Alterating lesions of melanoma, Clark level beyond 2 or Breslow thickness beyond 2 in a patient with an older age. The pathology of primary with Clark level 3 and Breslow thickness beyond 4 is an independent predictor to time of death, even without CNS metastasis. And these are very simple, cost-effective use of predictors that do not have to be anywhere specialized in the world for you to tell to your patient that what is going to be next for both of us to do and what's going to be your fate somehow. Can we use lab? Of course, we can use lab work, but that's for the clinics that have the means to do meaningful genetic research work. Now, when it comes to variants, I want to point out these genes that I have highlighted in red. These are all normal functioning genes of development human that have been hijacked, not necessarily by melanoma, but in the case of melanoma, if you were to conduct genetic studies, molecular studies in your clinic, and you were to see one of these genes coming out of the report, the chances are very high, one of these 6 genes, that the presence of one of those mutated genes shows you that that melanoma is going to metastasize, and actually is going to metastasize to the brain. Is that going to be a STAT3 activation? Yes. If that shows on your report, the chances are that the lesion coming from melanoma, the primary, is going to metastasize to the brain. Now, what about the fatal action of metastasis to the brain, which is the leptomeningeal invasion? Can we and are we able to predict? In some cases, yes, even before starting treatment. Not necessarily for metastasis, but even either primaries, which in this case would be kidney and colorectal, and some breast types of cancer. If you were to find a hemorrhagic lesion or a cystic lesion, the chances are that the progression to leptomeningeal disease is higher compared with any form of findings in brain metastasis. Now, I earlier pointed these 6 genes and additional STAT3 mutated gene, which is the 7th one. This is a primary, the melanoma of the skin, and this is what we find in normal pathology studies. These are simple hematoxylin studies coming out of the pathology lab. Are there differences in between the two? Yes, substantial differences, not just differences that we cannot see. In hematoxylin you would usually find commonalities, but when it comes to molecular studies and genetic studies, you would find differences in between what's the primary and what's the metastasis. Now, these are the differences we usually see in our reports in genetic studies. Not necessarily all clinics in North America do conduct this, but these are what we see in a primary on the left part of the column in this table, and then what we see in a melanoma brain metastasis. It goes to show the interaction in between the cells coming from the primary. When I say coming from the primary, I better say whatever is the origin of that primary with the local tissue in the brain. And in this case, in brain, it's going to be astrocytes, oligodendrocytes, and the milieu of cells within the glia. So we have been discussing this theory that the cells, as it's shown in the figure on the left, move from a primary, in this case has been depicted as lung cancer, and move to the blood. Well, fair enough. But only in animal studies that has been diagnosed. Yes, we do liquid biopsies to see if there is presence, but we do not identify tumor cells in liquid biopsies. We do identify particles of segments of genomes, either that being a DNA or an RNA or protein that we can use to move back and see what part of the mechanisms belong to a primary tumor, or is it from metastasis in cases that we have comparison data. So these animal studies have been substantially helpful, but not necessarily to exploit all avenues that we know about the mechanisms of the spread. This is just to show the advancements in technology, but not necessarily the advancements in the knowledge of the mechanisms of cancer biology, and more relevant to the cancer biology of brain metastasis. Here was that first paper, that's 1810. Is it the disease process of translation or it metastasis? And then here we have the first conducted PCR in 1983. In 2005, that was the next generation sequencing first ever done. And then from there on, it came to be to the price of $1 per sequence, which is very, very cheap. But what does it help? Technology not necessarily help. It is the idea that you want to put together in the collaboration with actors in the field for you not only to share ideas, but to bump to bring your ideas and bring questions for those that can ask more. It's more and better than just to have technology. Now, is it the circulating tumor cell? And what is the role of the blood-brain barrier? In my research work, I give credit to the blood-brain barrier only when it comes to physiological conditions. It is no longer a gatekeeper of any disease. For what we can tell is that under normal physiological conditions, I have been writing here 200, but actually there are over 400 substances, substrates, with significant molecular weight that can cross blood-brain barrier normally in everyday life, each one of us. Is that a significant number? Yes, that's a very significant number that can tell us the blood-brain barrier is not a gatekeeper. And the problem is that the only gatekeeper to this barrier is when it has to be crossed by treatment modalities, that where with the challenges that we face is how to have it worked, how to have it used into our benefits, to have these treatment modalities to cross the blood-brain barrier and be effective to treatment of metastasis. What do I mean, but is not a gatekeeper? So here on the left is a cartoon, but actually it comes from an electronic microscopic view of a blood cell. That's a capillary, and literally that's a red blood cell. On the right, there's a cryptococcus. Cryptococcus has its ways from generations even before I was born to find developmental pathways to cross this blood-brain barrier, invade the brain, and settle so nicely in the brain. We haven't evolved to the stage of Cryptococcus to understand these mechanisms. And Cryptococcus is way, way more complicated in its own mechanisms than what we know. When it comes to the treatment, I don't want to point, or I would not spend any time in the treatment, that's something else. I just want to point this immune interaction in between the tumor cell, which I would highlight here, and then the immune cells of our system. And tumor cells have hijacked the checkpoints of our immune system by producing substances, these small little antigens, which are usually proteins produced by a disarray of genes within the tumor that make it able for the immune system to not identify a tumor cell on its own. What I want to take out of this slide, please do not focus on the mechanisms of treatment, is just focus on the interaction between a cancer cell and an immune cell. It just goes to show that we haven't understood yet. There is more work that needs to do. I'm not focusing my research in that, but earlier, I'll skip this part. I can stop here for hours if needed, but lupus, which is one of the most common rheumatic disorders, is hijacking, a disarray, and malfunctioning of the immune system toward our body. Our body has been attacked not by one, but in general in lupus by 2 or more autoantibodies. And our immune system has failed to understand what is ours and what is foreigner, and considers ours as being foreigner. Now, when I was here, I just wanted to point this image in correlation with lupus. The mechanisms of the immune system in cancer are different than those of lupus, but immune system need not to be considered as the future necessary. Yes, it's going to be helpful in researching, in studying, in finding avenues to treat cancers, but not necessarily the fundamental bulk of it part, for very simple reasons. In diseases and disorders where this system is out of function or is malfunctioning, the risk of cancer is not as high or higher than in normal population. It actually decreases for some cancers, and that is breast, endometrial cancer, usually cancers of female organs, but not necessarily so as well in male. So do we have to focus everything on the immune system? I think not from that point on. Now, when I pointed out that these research work that we know, most of what we know in scientific of cancer is conducted in animal models. I just want to point out that nothing that I presented to you today has been conducted in animal models. Everything I've been collected and put here is being work done in humans. This goes to show that what we study in animals fails to be reproducible in real life. We cannot replicate that, and that's why I stay away to use animal models. I try to use liquid biopsies, samples from the tumors, either the primary or the metastasis, to understand how the two cooperate and work. Treatment strategies vary. When it comes to this example that I brought here is about melanoma, and when it comes to melanoma, even any other primary cytoreductation is very important. It is very important to the extent that if that can be done, it is first surgery of the primary, then focus on the metastasis. Now, surgery first in metastasis. Why do I say that? If there is up to 2 metastases approachable by surgery, in most cases, I would suggest surgery in brain metastasis for very simple reasons. I don't see much success when it comes to overall survival of radiosurgery or treatment modalities that we have at hand. So starting with surgery is not wrong. It's actually sometimes better. When it comes to resistance that the tumor has, and I will focus on something that's not melanoma, this is a cartoon depicting cancer stem cells in colorectal cancer. Substantial work, abundant work has been conducted. And what we stop to understand is that these quiescent stem cells that maintain the primary are resistant to any modality treatment that we have, unless we remove it surgically if possible. That's why I insist that if that can be done, surgery has better outcome when possible than combinations of all other treatment modalities. If we were able in the near future to understand and to target these quiescent stem cells, what does that mean? Those are stem cells that most of the time are not active, are radio-resistant, chemio-resistant, but those are always there unless removed surgically in bulk in healthy tissue borders. So too many treatment options, moderate results. I mentioned earlier that hazard ratio, which is how we measure what is the success out of the procedure in general, not only in cancer biology, but treatment in medicine, is 0.4. How much different is that from immune checkpoint inhibitors therapy? Nothing. You see the difference is 0.4 and 0.375. So how do we tackle those guys? I mean, the brain metastasis, we have not much. We haven't progressed into giving our patients overall better quality of life or survival. So I'm very cautious when it comes to the treatment modalities do I have to offer to a patient. What does that mean? I use those predictors that I showed you earlier to tell to the patient where we are before starting everything and what can we predict. Do we need to go through the hell for you to win 1 or 2 months of life, and what quality can I give you? If I do not give you any better quality, usually the patient would refute to go through the path of that treatment, and that's how things work in North America. Now, when it comes to treatment, they are not necessarily without side effects, and the side effects affect the quality of the life of the patient. And when it comes to that, for our patient, it is very important to be aware that after each of the treatment modalities that we offer, there is at least one side effect, and the risk exists. This is just a short list, but I can show you more. And the problem is that even with radiosurgery, you can induce leptomeningeal disease dissemination in a cancer patient which you have not opened any avenue or trajectory when you treat the primary by surgery. Now, when it comes to predicting leptomeningeal disease dissemination or insemination, it can occur during surgery. It is a considerable risk, but do we need to do the surgery? Yes, it is the best treatment option when doable, up to 2 metastases, even if you have 3 and you can approach it by surgery. Can it occur during stereotactic radiosurgery, which is very common and often used, except for small cell lung cancer? Some clinics still use a whole brain radiotherapy. I would argue against it, but that's not the point of this talk. Yes, even with stereotactic radiosurgery, there is the chance of insemination or dissemination of metastatic cells to leptomeningeal disease. And that's the risk, or the tract recurrence. Now, when I want to point out, if I am to combine 2 treatment modalities, I would start with surgery and do radiosurgery to the tract of the surgery. When it comes to demographic or clinical and imaging-based management decisions, I try to use those that affect the quality of life of my patient more than those that extend by 1 or 2 days or weeks or even a month the life of the patient, how better your life is with this treatment modality or not. And this is a list that I've come up with. It is the work of, I should say, several researchers put together. And these are very cost-effective nomograms that I would willingly offer for every one of us to share and use in the daily practice. It doesn't need to be anywhere special in the world. It can be even in a country with limited resources. Age is something that we measure in everyday life. It's just demographic. These are clinical predictors. And I go on with the list. And these are for centers that have advancements, and it goes to those that do studies in the cancer biology, that do molecular and genetic studies. Can we predict by using radiomics and radiology data? Yes, we can. We can tell our patient before surgery, before starting any treatment modality, that we are here with you. We see that your near future is this, and what we suggest or what we predict to be is this. If you have more than 1 lesion, if your lesion is hemorrhagic, or if there is a lesion that stands infratemporally, brainstem metastasis has the worst outcome of all possible confinings within the brain. Now, when it comes to follow-up, yes?
I apologize, please, but since we have to respect the time, we should forward to conclusion, please, for the next
Let's
speakers.
go there. My apologies.
I apologize for interrupting.
No. Adi, thanks for stopping me. I appreciate that. Wrapping up, I was about to get there. My apologies, I took longer. We can predict metastasis from a primary lesion. We can understand that there are differences between the primary and the metastasis. And seeking those differences, that's the research work that we are conducting. We are trying to find out what is the mechanisms that the primary makes it able for a metastasis to occur. I'll stop here. And I will thank you all for having me here today. And I extend my apologies for going beyond the time. It's a topic that I could take hours to talk about, but thank you. Thank you to all, and I'm open to any questions you might have.
Thank you for such a wide topic, very focused, and your great research in this topic. Do we have any questions from the audience? I believe this is a topic for itself. We should have a special webinar for only molecular biology of the tumors. Any questions from the audience, please? Okay, then we can move to our next speaker, Professor Ali Mehmeti, with a history of stereotactic and functional neurosurgery in Albania. Please, Professor Ali Mehmeti.
Thank the organizers for the invitation. I don't know how can I share this. Share the screen with you.
Dr. Ali Mehmeti, please, can you a little bit loud up your speaker since we don't hear you?
Do you hear me now?
It's a little bit better, but maybe just try a little bit more for the audience.
Yeah. Let me know how can I share the screen and how, because we are, yes. Yeah.
Dear Professor, do you see your PowerPoint on the screen? There is a green button. Yeah, fine. That's good.
You see?
Yes.
Just go for a full screen, please.
Yes. Is it okay now?
Oh, yeah, it's okay now. It's okay.
Okay.
Thank you.
Thank you very much for having me the chance to share with you this short talk about the history of stereotactic and functional neurosurgery at the service of neurosurgery in the main center of Tirana for neuroscience. I'm in charge of stereotactic and functional neurosurgery, but still we have younger neurosurgeons already who are taking over these procedures in our department. So what we are targeting, it is the simple things: Parkinson's, dystonia, essential tremor. And we started with the formation of theory and practical skills for ourselves. We were sent in Stockholm, then in Milano, where I had my long years of residency. I focused on stereotactic procedures in the Institute of Neurosurgery, where I had residency program, but as well in Carlo Besta Institute with Professor Broci and Franzini, who taught me about stereotactic and functional. And I did my first cases on Brown-Roberts-Wells and then Kozma-Roberts-Wells, but in Milan since '98. But in Albania, we had only the frame of Lexel. So when I made my way back to Albania, after my years of residency in 2006, we started with stereotactic open procedures with that frame. Only in 2015, we could do the first DBS cases for the sake of the expenses of these treatments. So we were involved in different publications that had in their basis the stereotactic procedures, and also the thesis on the reliability of stereotactic biopsy on grading gliomas helped me to understand better how to perform these procedures, as well as the use of image in this kind of, in this subspecialty of neurosurgery. This is also with a group of Professor Broci and Franzini on using deep brain stimulation electrodes for frequency lesions in a case that was infected in a small child with dystonia. But the same idea was thought to be useful for countries like Albania, who had not the chance to afford very high prices on those days, 2006, about implanting the whole system of generator and also the electrode. But the electrode was not so expensive, and we were thinking to use an implanted electrode in place used for a radio frequency lesioning in case of movement disorders. So in March 2006, we started with this model, and this is the test that I made with a simple CT scanner, aiming the foramen lacerum, but proved to be correct with the simple calculation on the screen with 90 degrees angles of positioning the patient and the frame on the CT bed. And then we used computerized atlas of Professor Franzini, which is online and free of charge. By then, we didn't have other computerized systems that we have now, but it helped us to choose the target and the entry point for the first cases. And the first cases were the biopsy in pilocytic astrocytoma of the thalamus in a 6-year-old boy. And then we implanted a DBS electrode in the GPI on the left side for advanced Parkinson's disease. And then we went on with the Lexel D frame. We did tumor biopsies of the basal ganglia. We evacuated an abscess of the thalamic area of a 27-year-old lady who did just fine and now is raising her kids. And we inserted the first DBS electrode ever in Albania for the coagulation. So this is the start. We were starting very enthusiastic. In 2011, we got the Model G, which is still in use, and it is used in many countries in the world. We use Surgiplan of Elekta nowadays for the calculation of the target coordinates, as well as the entry points in cases of biopsies or any other procedure. We have the electroradiofrequency generator in case of lesioning, and the set of electrodes like monopolar and bipolar. We use the narrow navigator, and we have this recent years the 3 Tesla MR of Siemens, which can show us better images of the basal ganglia. So far we have done around 100 and more cases of biopsies and routine evacuation of cystic lesions of the ganglion area. And we had done only 4 cases of bilateral subthalamic nucleus stimulation for Parkinson's disease with Medtronic Activa PC system. And also we helped other patients that were implanted outside Albania to change the battery in 3 cases. They all did fine. They do fine because they are very well selected. We have a very dedicated team of neurologists who are very capable of selecting the right patient for in order to have a good result after the DBS. And they are very capable of following the patients in order to arrange not only the parameters of stimulation, but modify the medication for them in daily basis. So these are the cases that we started to use when we didn't have the neuronavigator. In this case, it was a tumor, and we did a minimally invasive craniotomy to remove it. And these are cases of thalamic glioma for the biopsies. So this is in the pulvinar after the biopsy was taken. So we tested the precision of this system before implanting the STN bilateral electrodes for the Parkinson's disease. So we evacuated abscesses and cysts, and we used the Elekta, which is this frame shown here for the calculation. This is the first ever case of DBS electrode insertion in the GPI on the left side. Everybody knows about these systems, but we just wanted to sum up. These are the cases. We had a proctor who is very nice and capable guy, Professor Darko Huti from Zagreb, and we cooperate with them very well. We use the Harris method, Professor Harris, in London, which is the target is not functional in the way that you insert the electrodes guided by a CT and MR fusion, stereotactic CT and the preoperative MR fusion, and you have the control of the impedance of the insertion rather than the stimulation during your insertion of the electrodes. So we do this kind of method. We insert the stereotactic frame under local anesthesia. We send the patient for a CT scan, stereotactic. Then we fuse this preoperative MR with a CT scanner. We get the coordinates of the target and the entry point for both sides. And then we insert the electrodes on both sides under local anesthesia. So the patient is awake, is not sleeping. Then we interiorize the electrodes and get another CT scan with the frame and the electrodes in place. And we get a fusion of these electrodes with the preoperative MR. So you can see if the target is hit by the tip of the electrode, and then you decide to interrupt this part of the insertion, and you go on intubate the patient, remove the frame, and then tunelize the external part of the system with the generator of the impulses located under the skin of the chest of the patient. And in the end, you check the impedance of this system in order to know that all those touching points are in connection with each other in order to have a valuable system to be stimulated. In the post-op, we remove stitches at 12 days after surgery, and also the start of the stimulation on is not done immediately, but we wait for a week or two, and then we start gradually going higher up with the stimulation and modify the medication of the patient. So nowadays in Tirana, we do all these open stereotactic procedures for biopsies and evacuation of cystic lesions. We do DBS, and we are also able to do radiofrequency listening of the targets with all those limits and also indications that are nowadays still valuable even in Western countries that are having no issues about the money for the devices, but we still have this kind of problems, which impede the application of these techniques for everybody. So we have at least the team, and we are very willing to cooperate together. That is the basis of success in the cases that we have operated, and we hope it will continue. Thank you very much.
Thank you, Professor Ali Mehmeti, for your great lecture. Are there any questions? Actually, I have a comment about the lecture. For young neurosurgeons at the beginning of career, especially residents, functional neurosurgery doesn't look so attractive. But actually, it is the present and the future of the treatment of our patients. Do you have any message for young colleagues who would like to involve in a functional deep brain stimulation? Which are the obstacles they can find in the pathway? Which could be the main complication? How to avoid those complications in the patients? And what would be the strategy for the education for functional neurosurgery? Thank you.
Well, I think that the functional neurosurgery, there is no doubt that has a future as a subspecialty of neurosurgery, because all the spectrum of and the criteria of inclusion, and also the late recent years, the DBS indications are enlarging because they are also applied and FDA approved for epilepsy surgery and for psychiatric disorders as well. So research is going on in different fields in order to use effectively the DBS methods. There are also research going on in modifying the kind of stimulation in order to have nanotechnology involved. for sure, there is a presence and a future of functional neurosurgery. But on the other hand, if we consider that the brain tumors nowadays are being considered to be subject of surgery, but as well of other alternative treatments of drug treatment or chemotherapy and radiotherapy, you still need a sample to have the histological diagnosis, which is done through stereotactic biopsy. So you need a stereotactic and functional neurosurgery, and the knowledge for it should be taught in the schools of residency all over the world. This is my message to the younger neurosurgeons. In my department, we have younger neurosurgeons who are now 5 years after the conclusion of the residency program, who are doing routinely. Not all of them, of course, because we have different sectors, but the persons who are in charge of this are capable of doing it. I was myself with coronavirus at home, where I'm now, and they were doing the biopsies on basal ganglia tumors. I was very happy about that. So,
yes, maybe later telemedicine, robotic help will also be the part of functional neurosurgery. Also, there is a LITT treatment of deep glioma, which is actually laser interstitial thermal therapy. I had that opportunity to observe those surgeries in Weill Cornell in New York. So it's a great way of treatment of deep-seated glioma with a simple minimal invasive approach. And also there are some problems to overcome in, as I noticed, you use frame-based stereotactic frame. In my center, we use frameless, and we have still to overcome some of issues like mismatch of the point which we want to enter. But anyway, it's thank you. It's a great lecture, and that's future for neurosurgery. If there are no any other questions, we should proceed to our next speaker, Professor Yamamoto.
I think.
Hi.
Hello, Professor. Welcome.
Yeah, may I start
with your lecture?
Yeah, I'm going to talk about epilepsy surgery, but it's not related to glioma surgery. It's a pure epilepsy issues. I'm going to share my video clip. Hi everyone. I would like to express my sincere appreciation to Professor Yoko Kato and the faculty members in Bosnia, Herzegovina, Albania, and Kosovo for invitation as one of their guest speakers to this webinar of ACNS 2022. I'm going to focus on issues about microsurgical techniques of palliative procedures in epilepsy surgery, particularly corpus callosotomy and the device implantation of vagus nerve stimulation. This is my CV, but please take a look into the program book of this meeting. My message to young neurosurgeons: epilepsy surgery is different from the other subspecialties in neurosurgery because we need knowledge more about electroneurophysiology and epileptology for adequate placement of intracranial electrodes and resection of seizure focus. Epilepsy surgery is changing rapidly worldwide. Less invasive procedures will be chosen at the hand, such as SCEG without a craniotomy or laser ablation to seizure focus. Therefore, it will be totally different in 10 years. To begin with, there's no COI for this presentation, and I will show you a couple of video clips from my personal experience. Consent was obtained. Hi everyone, I would like to microscope should be encephalopathy, according to functions of procedure focus. Epilepsy surgery is changing rapidly worldwide. Less invasive procedures will be chosen at the hand, such as SCEG, without a craniotomy or laser ablation to a seizure focus. Therefore, it will be totally different in 10 years. To begin with, there's no COI for this presentation, and I will show you a couple of video clips from my personal experience. Consent was obtained from the family member in each case. When do we consider further evaluations for epilepsy surgery? Now it is said, failure to achieve seizure freedom with the two appropriately used anti-epileptic drugs as monotherapies or combinations for 1 year or 3 times the longest period seizure-free interval needs further evaluations for surgery. Then we normally perform long-term video vision monitoring, tests for higher cognitive functions, FVG PETs, etc. In many developed countries, these preoperative evaluations are done by epileptologists in neurology department. However, epilepsy surgeons should do this in my country because of shortage of pediatric and adult epileptologists involved in surgical evaluations. Palliative surgery is the other side of focus resection. Most of the patients who are candidates for palliative procedures have severe types of medical refractory epilepsy with multiple independent foci or symptomatic general epilepsy. Drop attacks are very risky in terms of a frequent head trauma. We should consider calcidomy as soon as possible for these patients. Otherwise, we will choose venous implantation. Corpus calcidomy by microsurgery is classic and one of the oldest procedures in neurosurgery and has been used for palliative option in medical refractory epilepsy, especially for drop attacks caused by tonic or atonic seizures in epileptic encephalopathy, such as Lennox-Gastaut syndrome or West syndrome. When we are approaching the corpus callosum, meticulous technique is necessary because it is surrounded by the major arteries and veins. And it is also located deep in the brain. Then I believe that mastering microsurgical techniques like cerebrovascular neurosurgery is very important before we do the first case of this procedure. In addition, methods and techniques of calcidomy, such as positioning, skin incision, and craniotomy, etc., differ from place to place, and then what I show you today is my preference or real practice from my experience. Positioning is also important. A patient is placed spine with the head and the upper body flexed about 30 degrees and fixed with a 3-pin skull fixation device. As callosal sectioning progresses, the head goes up and down to obtain better surgical views. However, elevation of the head, like a straight semi-sitting position, may have a possibility to induce embolism, and then close communication with anesthesiologists during surgery is required. The angle of a microscope body tube also needs to be changed as shown in the figure. As we go into the isthmus through the splenium, the head should be turned down and the microscope should be more vertical. After the head is fixed, shaving is done just along the marking for skin incision. When a patient is a small infant and the 3-pin skull fixation device cannot be used, the head should be fixed with a surgical drape. The skin incision usually consists of a U-shaped or C-shaped scalpel flap. The bone flap extends 4 finger breadth in front of the coronal suture and 1 finger breadth behind it. Craniotomy mostly provides intradural exposure of the right frontal lobe, but it crosses the midline a bit to allow exposure of the superior sagittal sinus and falx. The dura is opened in a C-shaped fashion with the dura flap based along the superior sagittal sinus. The operating microscope is brought onto the surgical field, and an inner hemispheric exposure is performed on the right side of the falx using a microsurgical technique. Once again, major bridging veins should be spared because venous insufficiency or the brain swelling or venous infection in the worst case must be avoided. Self-retaining retractors are placed for interhemispheric exposure. At the beginning of dissection, I usually choose a straighter type blade. I also need another blade to retract the falx. Then I started cutting arachnoid membrane, crossing the interhemispheric fissure, or adhesion between the bilateral cingulate gyri with microscissors. Due to previous infections such as meningitis or encephalitis in infancy, or previous frequent head trauma with possible intracranial minor bleeding, dense adhesions are occasionally encountered. We must be careful not to dissect into a subpia plane. However, aspiration of the hemilateral cingulate gyrus may be necessary in some cases. Then the corpus callosum with the stark white color comes into view, usually between the two pericallosal arteries. I move forward again to split the bilateral frontal lobes to see the genu well. We can see here branches of the carousel marginal arteries. When retractors are placed deeply, the whole genu is exposed and the two pericallosal arteries are arising from the chiasmatic system. Superficial small veins on the corpus callosum can be coagulated and cut. Then I start aspiration of the corpus callosum between the two pericallosal arteries with a section with a diameter of 2 millimeters. After a little bit of aspiration, I usually replace the spatula with a tapered shaped blade and retract to the edge of the corpus callosum. That makes sectioning easier and less retraction on both pericallosal arteries, cingulate gyri, and other portions of the interhemispheric fissure. It is also useful to use the left hand with another section as the third retractor. Sectioning is extended anteriorly through the genu and the rostrum. We should take care that the pericallosal arteries are followed well under our direct visualization. When the genu and the rostrum are separated, the anterior cerebral arteries and the subarachnoid space are visualized. Carousel is placed into the separated space of the corpus callosum. The more sectioning is continued posteriorly, further dissection of the bilateral cingulate gyri is necessary depending on the extent of the callosal section. The extent is different from a case to another. In my practice, most of the cases obtain 2/3 or 4/5 sectioning. The second stage will be performed if an additional sectioning is necessary. For the section of the splenium, posterior interhemispheric approach may be chosen. However, I'm used to approaching from the same craniotomy and the same route to reach the posterior part of the corpus callosum. It is right and obvious that there is occasionally dense adhesion by the previous anterior causotomy, but I think it is possible, in my experience, to accomplish a sectioning of the splenium with the same craniotomy. After that section of the body, we move on to the isthmus. The isthmus is narrow and cylindrical shape. Then the method of aspiration is different from that of the anterior part. In aspirating the genu and the body, the section tube moves back and forth, but in the isthmus, aspiration is like making a small circle. The residual tissue should be removed from the bottom of the cingulate gyrus. In this case, 4/5 sectioning was carried out. And the sagittal is placed into the separated space again. A post-operative MRI shows that the carousel sectioning is completely carried out. Vagus nerve stimulation, VNS, is one of the major options in epilepsy surgery at the present. Candidates for intracranial epilepsy surgery will be probably 1/3 of the patients who undergo further evaluations as mentioned above. Therefore, patients who are not suitable for intracranial surgery should be also assessed for VNS implantations. Positioning is very important in this device implantation. The neck is well extended to expose the vagus nerve easily deep in the neck. An obese patient with a short neck is the most difficult case to find the vagus nerve. I will show you my practice in VNS implantation. The skin incision is placed along the skin winkle at the level of cricothyroid ligament. 2 or 3 finger breadths are enough, but for trainees, more incision will be necessary. The sternocleidomastoid muscle should be retracted laterally, and we will find the borderline between the inner hyoid muscles and the outer sternocleidomastoid muscle. Blunt dissection is used to prevent unnecessary bleeding. Then we see the carotid sheath with the carotid pulsation. The vagus nerve is normally located deeply between the common carotid artery and the internal jugular vein. Do not grab the nerve directly with the forceps. Just to grab the sheath around the vagus nerve. The nerve is isolated with the vascular tape. And the remaining membrane should be cut and released away from the nerve. Too much peeling of the membrane from the nerve is not a good idea. because the membrane often contains the vasonervoram. A chloride retractor for cervical spine fusion is placed. And at the tip of the lead is a slip under the vagus nerve. The helical anchor tether, positive electrode, and a negative electrode are placed. This is a positive electrode. And finally, this is the negative electrode. The tip is cut, and make sure that the electrodes are well placed. Then the lead is affixed with the tie downs to the muscle fascia. We move on to placement of the generator. It is the same as the neck. We use a wrinkle for incision. Normally, space for the generator is made just above the major pectoralis muscle. But for small children or very skinny patients, the generator is occasionally placed between the major and the minor pectoralis muscle for cosmetic reasons. The lead and the generator are connected. The tunnel is used to connect from the neck through the generator pocket. And then it is connected to the generator. And we do intraoperative testing to see if the system is well working. And finally, the one is closed.
Is the video paused, Professor?
This is the last slide and shows tips in these palliative procedures. Change the position of the head and the angle of a microscope as carousel progresses from the genu to through the splenium. Enough freeing adhesion between the bilateral medial frontal lobe is necessary to say the genu well. Do not start aspiration without a sufficient surgical field. Find the septum pellucidum as soon as possible in the beginning of carousel to make sure of the midline. In VNS, neck extension is important in this procedure. Blunt dissection should be used to prevent unnecessary bleeding. Leave some membrane around the vagus nerve for protection and the blood supply. Thank you very much for your attention.
Thank you, Professor Yamamoto. Great lecture. Great video also. Thank you so much for sharing your tips for this very important strategy in surgery. Are there any questions? Also, I have I can say it could be a basic question since I don't have too much experience in this field, but all of us, we know the types of the epilepsy which can be treated, but what would be an ideal case for a beginner as a young neurosurgeon for each procedure? Which is the best ideal patient for vagus nerve stimulation, and which would be the best case for a beginning for corpus callosotomy? Thank you.
Yeah, for corpus callosotomy, I think it is best for young neurosurgeon or trainees to perform patients with Lennox-Gastaut syndrome. These patients may have spasms and drop attacks due to tonic seizures or atonic seizures. Then it is patients have a very poor life and ADL. Then we should consider as soon as possible to perform these procedures for these patients. And then in VNS, I think there's indications for VNS are very more and more cases, I think. And then if a patient has bilateral temporal lobe epilepsy, and now most of the cases, I would think dominant side of a seizure focus, right side or left side, but sometimes 50-50 cases. Then in these cases, if we reject one side, it doesn't work. Then as a palliative option, we recommend VNS for these patients, bilateral independent foci.
Thank you. Thank you for an answer. Any other question? Okay, then we can proceed with our next speaker, Professor Nakatomi, with functional preservation surgery of acoustic neuromas and meningiomas. Please, Professor Nakatomi.
Yes.
Thank you.
Yes, good afternoon, everyone. And I'm really sorry for late my opportunity. It's a great honor to be here to present our study. And first of all, I really appreciate Professor Kato and her colleagues to give me this opportunity to expand our knowledge to the world. I'm going to talk about our study on the functional preservation, particularly for acoustic neuromas and meningioma surgeries. They are most popular surgery in benign brain tumor. Then the ultimate question for these two popular brain tumors should be how can we precisely visualize the nerve position, and how can we visualize the neural function during the operation? To answer these questions, we have introduced several new technologies. But first of all, basic knowledge is very important. The origin of vestibular schwannoma is always starting from the bottom of the internal auditory canal, right here, on the superior vestibular nerve, or inferior vestibular nerve right here. Then they can grow along the vestibular nerve so that ultimately they are sticking into this V-shaped zone created by facial nerve and cochlear nerves. That's most important knowledge to deal with this benign tumor. Also, we would say, as far as the tumor is growing under the within the cochlear and the facial nerve V zone, they should have the remnant of vestibular nerve covering. We can see these covering membrane as a semi-lucent membrane sticking to the tumor. We would say this is a subperinoidal membrane. As far as we are protecting subperinoidal membrane, we should be able to untouch the facial nerve and the cochlear nerves. Then for monitoring, that's very important. We introduced not only the AVR, but also new dorsal cochlear nucleus action potential monitoring. Instead of put the needle to the scalp, we put the plate type electrode right onto the dorsal cochlear nucleus so that we can get 10 times to 20 times bigger amplitude of the hearing response within 7 to 10 seconds. Then let me show, and also for facial nerve, we have the continuous stimulating electrode, which can sit right on the brainstem facial nerve root so that we can stably stimulate and get the every 3 seconds response. Also, we are using the 3D computer technologies to visualize the facial nerve and the cochlear nerves. Particularly, contrast enhanced fiesta image is useful for facial nerve, and for the diffusion tensor tractography is good for cochlear nerve detection. Let me show several cases. This is a lady came with hearing decline. The tumor size is 3.4 centimeter, and what we should do. First of all, we try to visualize the cochlear nerve position with these 3D technologies. And we thought cochlear nerve green is caudally shifted and her facial nerve red is pushed deeply into the anterior part. Then this is a real operation. We use both red and green electrode. We use always the retrosigmoid approach, then splitting the cerebral medullary fissure between the flocculus and the 9th, 10th nerve. Then I put the electrode into the foramen lusca. Now we are putting the facial nerve root stimulating electrode behind anterior to the gross pharyngeal nerve. Then we are stimulating the tumor capsule. Then we don't see any response with a 2.0 or 1.6 milliampere stimulation. Then enucleate like apple. Then we will see clearly the cochlear nerve position now. Then we can leave 2 or 3 millimeter protecting vestibular nerve remnant membrane to hold the fragile cochlear nerve as it is positioned. Then after taking out the most of the tumor out, then shape the rest. And as we expected, her cochlear nerve is positioned caudally, and the facial nerve is right there. Then this is a trend graph. As far as we are continuously record from this device, we can calculate the phase amplitude preservation ratio every second. Then we can plot these percent as a line graph. Then we can create this trend graph for each nerve function. First two column is depicting the facial nerve function. The last two column is for hearing. In this patient, we didn't see any decline for both facial nerve ocular muscle or oris muscle, and the ABR internal delay, and the dorsal cochlear nucleus action potential amplitude has been preserved more than 78%. She didn't show any hearing decline, and her function has been preserved. And we, after accumulating these experiences, we have noticed in order to preserve the same grade hearing preservation, we need to maintain the amplitude preservation ratio more than 35% for hearing. Let me show another case. This lady came with also hearing decline and showed a 2.5 centimeter tumor. We attacked this tumor with the same technologies, but we had the facial nerve paralysis afterwards. Then if we look at the trend graph for this patient, the facial nerve function has dropped down to 42% for ocular muscle, and oris muscle down to 27%. Then what happened at these particular situations? Since we can record these situations together with electrical recordings, I am dissecting the tumor within the internal little canal without debulking. Then by touching directly to the facial nerve, we have encountered some EMG burst. Now we are touching the facial nerve without debulking the tumor. Now EMG A train started, but I didn't notice. Then we repeated several dissections 2 or 3 times. Then a continuous facial nerve response dropped markedly. So we think EMG burst is a pre-cautious sign. Also for facial nerve, we have gained the knowledge about for same grade facial nerve normal function preservation. We need to obtain, keep the amplitude more than 60%. For the House and Blackburn grade 2, at least we needed to keep more than 50%. Then during this period, by using these two technologies, we had gained the 73% hearing preservation and 81% normal facial nerve function. Then I'm moving on to the meningioma surgery. Then for meningioma surgery, we also think how the ultimate question should be, how can we visualize the tiny feeding centers and the piral feeders for meningiomas, and how can we visualize neural function associated with the dangerous area? This is a concept advocated by Professor Yasajiro, and his text delineated this illustration. Meningioma has always a big feeding artery, which is penetrating the bone and the muscle and the dura mater. We can say this is a feeding center always 1 or 2 here. And as the tumor gets bigger, the tumor can take some supply, blood supply from the pial arteries. We would say pial feeders. If we can clearly differentiate these 2 types of feeders before the operation, we have only to eliminate these, particularly for feeding center blood supply at the beginning of surgery. That scenario changed my practice. Then also we can use, particularly for the, for example, if we look at the paraclinoid meningiomas, if the tumor has the sphenoid ridge type, they have always 2 feeding centers, one recurrent meningeal artery from the anterior part, second meningohypophyseal trunk from the back. For planum sphenoidal type, which has the anterior and posterior ethmoidal type feeding centers. Then for the this is tubercle musella type tumor, some unilateral recurrent meningeal artery feeding center as well as posterior ethmoidal artery feeding centers. As once we are familiar with this type of the feeding center classification, it should be helpful to construct the surgical strategies. Let me show some cases. This lady has a sphenoid ridge meningioma, came with a right side visual acuity decline. Looks like carotid artery is pushed posteriorly. Then we use the 3D technologies, and this tumor pushed to the optic nerve in medially and pushed to the carotid artery posteriorly. Then feedings, as regarding for the feeding centers, as we expected, this has one from the recurrent meningeal, the other from the posteriorly from the meningohypophyseal trunk. You have only to eliminate these feeders from the front to the recurrent meningeal artery, from the back to the meningohypophyseal trunk, along the petroclinoid ligament. That's the strategy. Now we are approaching front on the right side through the Transsylvian approach, splitting of fissure. We are seeing the M1 segment. Then first of all, we are eliminating the feeder, first feeder from the recurrent meningeal artery at the junction of the sphenoid ridge here, then cut. Now the tumor gets pale. Initially, we looked at this tumor very bloody. Now it's getting pale. Then we can now use a serrated scissors to debug the tumor. Bloodless surgical field. And now we are splitting the M1 or A1 perforators. As long as the blood supply to the tumor has been eliminated, it's getting easier to dissect the carotid artery of the tumor. And around the optic nerve, it's very important to open up the optic canal dura and optic cis dura before manipulating the optic nerve. Then now we can split the M1 or A1 perforators. Since the tumor debulking has been completed, the tumor looks very pale. Then if we look at this case as from the trend graph electrophysiology, we didn't see any VEP continuous monitoring decline. We have maintained the amplitude more than 50%. Then her visual field, she had some quadrant decline, quadrant deficit, but her visual acuity improved from 0.1 to 0.7. That quadrant deficit is still the problem. probably from the drilling heat might be the cause. Post-operative she looks fine. And next case, same sphenoid ridge meningioma case with visual acuity problem. But now the problem was the carotid artery. Angiogram showed the PCOM anterior choroidal and M1 and the C1 has been involved. That's the problem. Then we look at three-dimensionally. This meningioma has a feeder from the top, from the front, recurrent meningeal, and the feeder from the back, meningohypophyseal trunk. You can eliminate the blood supply by dissecting along the petroclinoid ligament from top to the back. Then we do some 3D rotational video strategical observation with my colleague. We will see two green feeders coming from the anterior part and the posterior part. Then optic nerve is pushed medially, and in the middle, the purple is tumor, and the middle is red middle is carotid artery. It's quite squeezed. We thought that this patient has a high risk of the carotid injury. Now we are taking out the crinoid segment of the bone, then splitting the Sylvian fissure. Then we put the STA M2 bypass first to prevent any ischemic complications. Then now we are approaching to the recurrent meningeal artery feeders. It's already gone. Then open up the optic canal dura here. Then now dissecting the tumor of the carotid artery. The basic concept is secure the proximal part of the ICA, then dissect from the M1 segment. But unfortunately, this patient, this carotid artery ruptured. We have prepared a temporary clip as well as Gore-Tex lap clip material, which has been designed for the cardiac surgery. But temporarily, we can maintain the anterograde flow by wrap clip technique. Then we move further on the tumor dissection. Since we know this patient has a tumor along the posterior communicating artery, then splitting along the posterior communicating artery, taking out one side completely, then move on to the other side. That's the principle. Now we are taking out the tumor along the anterior choroidal artery, then dissected most, but unfortunately the carotid artery gets to the pseudoaneurysm. Since we have already created a big bypass, we sacrificed this part. Then when we look at this patient from the monitoring standpoint, this patient's motor evoked potential maintained more than 50, and VP amplitude gets better for some reason. And her visual field and acuity has maintained. Then she has no problem afterwards. But there is some remnant medial to the carotid artery. We are keeping an eye on that. So in conclusion, these technologies, 3D technologies, visualizing the disease nerve and the feeding centers and associated neural function is very useful for benign tumor surgery, popular vestibular schwannoma and meningiomas. And understanding the neural threshold should help to balance the functional preservation and the radical resection of surgery. Thank you very much for your attention.
Thank you, Professor Nakatomi, for this wonderful overview of anatomy, imaging, advanced imaging, and your surgical technique. which we have seen here, and great cases. Do we have any questions? Maybe Professor Kato have a comment of.
Oh, thank you very much, Professor Nakatomi.
Thank you very much.
Always your impressive lectures, always very, very impressive. And just I want to know your technique, perioperative planning with the 3D image or computer graphic image. So is it everybody can available now, or let us know, please.
Yes, thank you very much for your question, and I really enjoyed this meeting. And this 3D technology is now available, commercially available as a grid, the computer softwares, and most of the part radiological technician can handle that. DICOM image incorporation and some CT, MRI, and angiogram data conversion, the computer software can automatically do. So we can skip any scat work for the neurosurgeon. Well, neurosurgeon have only to strategize, what can we say, the simulate the surgical craniotomy and pushing the brain towards the anterior posterior. That's the neurosurgeon's job. But we need to collaborate radiological technician and the radiology department to enhance, to promote this type of clinical application.
Thanks. Even though I think a very skillful technique, just like you, will be needed, I think. So maybe Casper? Hi, how are you? Hi, yes, please, go ahead.
Just one comment on Nakatomi. I think it was a fantastic talk, most beautiful.
Thank you.
And it would be nice if you put into the chat box the link to the radiographic tool, because I think most neurosurgeons are very afraid of the time it consumes to pre-surgical data planning, and also what sequences to obtain, because for TTI images, you know, it really depends on your segmentation algorithm, what resolution you will get for the facial nerve, for the cochlear nerve. And you have shown beautiful pictures that I think will facilitate this for colleagues joining this particular area. And it's very encouraging. Thank you.
Thank you very much for asking. Our department is very happy to help everyone interested in these technologies. And instead of putting the chat, or I can share some protocol with anyone from this meeting. And we can help to promote this technology to help patients all over the world. Okay.
Thank you very much. Adi? Thank
you, Professor Nakatomi. Thank you once more time. I would like to introduce our next speaker from USA, Professor Eckhard Kasper. Let me introduce Professor Kasper shortly. He is a specific expertise as a clinical specialist and academic clinician with the focus in brain tumors, radiosurgery, and functional disorders such as lesional epilepsy. Besides scientific emphasis and clinical application, Professor Kasper extensively works with the Boston scientific community, with colleagues from neurosurgery, neuropathology, neuroradiology, neuro-oncology, and ophthalmology as well. He especially enjoys educating young generation of healthcare providers, and in that way, Professor Kasper is part of EANS, ACNS, WFNS, and Pan America Association of Neurosurgical Societies. Professor Kasper will have a talk about conventional VP shunting. So please, Professor Kasper, you can continue your lecture. Thank you.
Thank you. Let me just find my lecture on the screen here. Give me a moment. Show all those. Oh, give me one moment. The lecture just disappeared for a second.
Yes, please, just take your time.
Here we are. So can you see my screen?
Yes, just please go for a full screen.
Yes, yes, 1 second, slideshow. From the beginning. All right, so thank you very much, Yuko, for having me to join you for this exciting event. I always say that the talks that I try to contribute are really intended for residents and fellows who would like to join a new area of neurosurgery. And therefore, I'm starting at some of the basics. And you may think that this topic seems a little bit off topic because it's hydrocephalus and functional disease, whereas your conference is really on gliomas and functional disorders. But for me, you need to understand it from my background. I trained in a specialized center in Germany before I moved to the United States. Our neurosurgical center was for stereotactic and functional neurosurgery and neuro-oncology. And we used a lot of technology, especially stereotactic techniques, to address different problems. And one of the most functional, most typical problems we see now in practice is hydrocephalus, which is really also a functional disorder. There's nothing wrong with the patient other than that you have too much CSF on board and therefore your circuitry is disrupted. So I want to use this briefly as an introduction to the problem of hydrocephalus. And then based on what I will say about hydrocephalus and to treat this, show some atypical forms of hydrocephalus where smart techniques that I've learned in functional neurosurgery from stereotaxis will help us to solve a similar problem. So I have nothing to declare other than that I also work on the World Federation Committee for Anatomy, now EANA, and I've published extensively on the topic of shunts in the setting of oncology and otherwise, so I will give some references throughout the talk if people would like to follow up on some of the issues. So I first want to tell you, what am I going to talk about today? It's really the background, conventional VP shunting for NPH, and then 3 innovative scenarios for stereotactic internal shunting procedures. These 3 topics are unilateral hydrocephalus from an entrapped temporal horn, which we see in some tumors, obstructive hydrocephalus from arachnoidal cysts, and obstructive hydrocephalus from Carvin Verge, which you may encounter in your practice. Let's start with some cerebrospinal physiology. This is rather simple. We all know that CSF production occurs largely in the ventricles. We have about 150 cc's of CSF on board. Only 25 cc's to 30 cc's is in the ventricle. The rest is around the brain. It's renewed about every 24 hours, which gives you a production rate of about 20 cc's per hour. And a CSF pressure is slightly above CVP pressure, which helps you that the CSF is pressed into the veins for reabsorption. That's the current concept. Normal CSF should be near colorless, low protein infused cells, and it's circulating constantly with a number of different functions like metabolic waste clearance and cooling of the brain, as well as pulse dynamic compensation. Now, when you think about non-obstructive hydrocephalus as an example, what is really NPH, right? We want to look at the clinical problems, the diagnosis, and the solutions, because I truly believe that shunting should not be done by the junior resident. We had a beautiful seminar yesterday with Keki, and we all agree that one of the big mistakes we make in our community is that we give 2 of our most vulnerable patients, the trauma patients and the shunt patients, to the most junior resident to learn how to operate. But I actually think that these are fairly complicated diseases, and the most experienced surgeon should show how to do this best to decrease your associated morbidity. So for NPH, let's start with the definition. It's a normal pressure, which means the range of pressures you will encounter is most likely quite normal, but there's an abnormal fluid buildup of cerebrospinal fluid in the ventricles, which then leads to some function impairment, largely cognitive and associated symptoms. So they really have an excess of fluid and a problem that they can't drain it. If you look at the classic clinical presentations, it's usually difficulties walking, some form of dementia or cognitive decline and incontinence. And you'll find this in every single textbook. We're very familiar with it. How it comes about remains a mystery, but hydrocephalus often presents with decreased functional decline, maybe from a stretch of fibers. So the clinical workup includes diagnosis, obviously, by review of symptoms and physical exam. Imaging, usually a CAT scan is good enough, but an MRI scan is quite helpful in understanding physiology. A spinal tap, which often suffices to get an opening pressure, and the CSF analysis. Some people place a lumbar drain over a 36-hour period, and they want to see whether the patient gets better after draining off a larger amount of volume for possible benefit of surgery. So we use a timed walking test and see how the patient walks for 30 feet after a lumbar tap has been obtained. We do a cognitive test before and after, and many patients report 24 hours after the tap still improvement. And here you need to ask the family how the patient performs, because you only see the patient once or twice on the ward. Most families are much better resources for judging their family member in terms of cognitive function. Things to consider. I really think NPH is a functional disorder where you have a mismatch of the amount of CSF and the ICP and the tolerance level. So the way I explain this to my residents is there isn't much that changes, but maybe you used to be able to tolerate an ICP of 10 and 12 and reabsorbed CSF. But for some reason, through a disease mechanism that is hard to understand, our tolerance drops down to 8. So suddenly a normal ICP of 12 is exceedingly high for you, and you can't reabsorb this amount of CSF. And therefore we need to get rid of that incremental 4 centimeters of ICP, which is not a lot. And the first thing I truly believe in is don't use a fixed valve pressure for a problem that you don't understand yet. I truly believe that a programmable valve is the method of choice because the revision rates are significantly lower, the complication rates are significantly lower, and your chances of picking the wrong valve based on a single point of measure when you do your LP, whether it's opening LP pressure or end of LP pressure is a debate, but a single point measure is probably not good enough to find the optimum valve setting for the patient in front of you. I also think it's really important to tell the patient what is to be expected. Many patients think they will be perfect the day after surgery. That may not be the case. Many patients report their incontinence gets better first, their cognition gets best last, and their gait is sort of in between, depending on how the test was before. So post-op close clinical surveillance is really important. You should put these patients into a protocol, see them not just the first 3 days after surgery, but then a week later, a month later, 3 months later, to see your progress of improvement. As much as I think that shunt surgery is very much routine, I set it up as a protocol. I do it as standard of care. I do not do ETVs for NPH. I used to have colleagues that are willing to perform a third ventriculostomy for NPH. I think that makes, physiologically speaking, 0 sense. There may be a few patients in these series that have responded adequately, but I think they have a different disease. And I think a programmable valve is the way to go. I think it's general anesthesia. It usually takes 45 minutes. Can be done the same day home if you do it as first case of the day. But I don't recommend this because you wouldn't see the improvement of your patient. So depending on your hospital setting, try to keep the patient in-house for 2 days to see your outcomes. Then things to consider. It's really a mismatch of ICP and tolerance. So I just picked these numbers arbitrarily, 12 to 8. So I think you want to optimize how do you make that mini improvement to change your reabsorption rate. And I think it should be done in expert teams, both for limiting proximal and distal complications. And we have published that extensively. And we should use post-op imaging, including newly described techniques where you can use a translucent burr hole cover and use ultrasound to immediately post-op check how your ventricles are responding to the adjustment of the valve. It's cheap, it's available, it will come as a technology. I think you should watch out for this new trend of doing bedside ultrasound-guided ventricular surveillance. It's a beautiful technology that is on the market. It's just not yet out there. And then why do I build clinical and OR teams with experience? I really have an experienced abdominal surgeon with me in every single shunt case because I place them with laparoscopic assistance. The reason is you have less pain and you can place the distal end of the catheter over the dome of the liver. There will be 0 adhesions, there is no omentum, there is no distal failure. In my last 10 years of neurosurgical practice, I had 2 cases of shunt revisions because of distal failure ever since I adopted this technique. So I really recommend using an endoscopic abdominal surgeon. Will not add significantly to your surgical time. They start at the same time you do. Their sole purpose is to place that little catheter over the dome of the liver, and you will be much better off having no distal complications. And then we built a little pathway, and we created a hydrocephalus clinic that we do this together in practice. Now I want to use this, what we've just learned about NPH, and show you innovative scenarios to treat occlusive hydrocephalus, which is very different. In this case, there is an amount of CSF that can't get out of its location. And the first one I want to present is unilateral entrapped temporal horn. So here, the hydrocephalus is very different. It arises too often lesions in the ventricle or some form of obstruction that clogs up the CSF outflow produced by the choroid plexus. Has been described, for the last 30 years. But lesions can be anything: neoplastic, infectious, inflammatory, hemorrhagic. So you will encounter this in your practice no matter what your specialty is. This is usually how this looks. So it could be from a ventricular meningioma sitting in there, solitary fibrous tumor, or it can be from a small amount of blood that sits and just doesn't allow the temporal horn to drain out laterally. And the usual feature that you see is there's just one ventricle that's entrapped, the temporal horn goes up. And these patients show very subtle cognitive decline. They complain of a little bit of headache and they're just a little bit off. So pre and post-surgical cognitive testing will pick this up, or diligent imaging that you put around every single patient that you encounter in your practice. So my patients, when they have tumor surgery, they will get a CAT scan 4 hours after the surgery just to rule out hemorrhagic complications, an MRI scan 24 hours after surgery to confirm that there's no delayed complication and the tumor is out. And I often pick up a problem like this if it happens post-surgically on those scans or on the first follow-up. But more frequently, it's the presenting problem the patient comes in with. So here the problem is it's a so-called syndrome of the trigone when the tumor sits right here in the junction of frontal and occipital horn. It's a stretch of parenchyma meninges with compression of Meyer's loop. So these patients have very subtle symptoms, and the symptoms are usually this combination of headaches, some cognitive decline if it's on the right side. If it's on the left side, there's an addition of receptive dysphagia. There may be a little bit of homonymous hemianopia, and there can even be some control hemiparesis. So we have seen this happening too. Now, what are the treatment strategies if you have such a block? Well, you could just put in an EVD and then think about what happens next, and you can think about shunting. You could do temporal horn to peripheral shunting just as VPS, but the problem is the driving pressure is very low. So picking a right valve for this particular problem is really difficult. You could do stereotactic shunting and shunt the temporal horn to the frontal horn by putting in a catheter stereotactically. You could go in open and fenestrate the fissure and come in, drain this temporal horn through the choroidal fissure. Or, and that's what I want to propose, think about a lateral ventriculocystonostomy. I will tell you about that in a second. The argument is we don't want to use the other approaches because an EVD followed by open surgery is really 2 interventions with higher morbidity. If you shunt the temporal horn to the conventional way, there's a higher chance for device failure rate. There's also risk of seeding in oncological cases. If somebody has, for example, a metastasis to the choroid plexus, which is quite frequent, you don't want to shunt these patients because there could be seeding to the abdominal cavity. You don't want to do frontal to temporal horn shunting because that's a hard corridor to do, and that increases your risk. And you may have 2-axis corridors and a T-valve. And choroidal fissure fenestration is really something that is not in everyone's hands working out well because there's a risk of vascular injury. So why would we add another technique? And I think here the thinking has to be make your approach the least invasive and aim for the highest quality of life, especially in patients that have very short period of life to live on or already had lots of procedures. So this is one of these cases. That's one of the index cases that made me think about this. This is a 41-year-old female that had meningiomatosis. So she had previously 4 craniotomies for removing of meningiomas. And you see she even has here a small frontal meningioma. Then she showed up during surveillance and developed this right-sided choroidal plexus meningioma by mistake or by bad luck. She was a lawyer with KPS of 100 and no neurological deficits at this point. So what would you do? The smart thing is initially you wait and watch and see what happens, because sometimes the tumor doesn't grow significantly, but in her case it did. So we decided after 4 craniotomies, maybe we should treat this mini tumor with stereotactic radiosurgery, which we did. We did use the cyber knife. We delivered 12.5 or 13.5 gray of radiation. And we thought this is beautiful. Patient goes home next day and patient can stay a lawyer and work and there's no morbidity. But we underestimated biology because after we radiated this small tumor, there was intense inflammatory disease. And after the radiation-induced inflammation, the patient developed an entrapped temporal horn, as you can see. And now we were really at 3 months faced with a symptomatic patient who had an entrapped temporal horn, had headaches, had some form of tinnitus, and she wanted to get this treated. Well, here the problem then is you don't want to operate right after radiosurgery in an inflamed setting. So what would you do now? And this made us think about this approach, which is pretty unique. But if you look at coronal reconstructions of your brain, you could actually see that the lateral horn of the ventricle, temporal horn, and the prepontine cistern is in the same plane. So if you come in with the right trajectory, you could put in a Rickham catheter and drain the temporal horn medially into the prepontine cistern. So this is a really smart, technically somewhat challenging stereotactic catheter placement for internal shunting. I only do this with a fixed frame. You pre-measure the length of your catheter. You get some additional side openings in your plastic catheter, but it's very safe. It's very familiar and someone who does a lot of stereotactic work, very short surgery, minimal morbidity. So the patient was able to go home again 1 day later after 1 hour of surgical time with no added complications. And this is the result. The patient now at 3 years later had complete control of her tumor treated with radiosurgery in the outpatient setting, had resolution of the temporal horn that enlarged, and had no further symptoms, which I think is perfect outcome in someone who is high maintenance because she's a lawyer, high risk because she had previous surgeries, and a complicated case to begin with. Conclusion, well, this approach takes advantage of proximity of the temporal horn to the prepontine cistern because the topography gives you a very good trajectory to connect the 2 compartments, and it obviates the need for endoscopic manipulation and doesn't require a device. There's no shunt valve involved, so you will likely not have any failure rates from device failure, and your low pressure of the temporal horn drives still enough drainage into the prepontine cistern, so you're not worried about not getting the valve setting right. The only thing is you need to know your anatomy, and that's why we're here. Well, second setting is obstructive hydrocephalus from an arachnoidal cyst. And I want to show you this with the example of a quadrigeminal plate arachnoidal cyst. Although 2 days ago, I just encountered this patient that I have the images on here. This was a patient with the glioneuronal cyst. You can see there's a large cyst and the ventricle is right next to it. I was really tempted in doing exactly the same thing, put a stereotactic catheter through the cyst into the lateral ventricle. But when I looked at imaging more carefully, I discovered that there were lots of septations in this particular arachnoidal cyst, and I felt I wasn't able to get the trajectory right to drain all of them from the right angle. So in this case, I did an open fenestration. But for the purpose of this talk, I want to show you arachnoidal cysts can be drained internally really well. I wouldn't resect them openly in most cases. The quadrinomial arachnoidal cysts are rare events. They only make up 2.5% of all arachnoidal cysts. And these lesions can be associated with hydrocephalus in a number of different locations. The ones in the suprasellar component can cause obstruction. The quadrinomial ones usually obstruct the aqueduct. And infratentorial arachnoidal cysts, although rare, can press on the fourth ventricle. So this is the case that I want to discuss in a moment. We want to think about three treatment strategies. Either we address the causative arachnoidal cyst, then we can do an open surgery in a case like this and come in from posterior supracerebellar infratentorial. But the problem is it's very compressed tissue, very little space here. So I think it's rather risky. We could do focused cystoperitoneal shunting, which has been described, but I'm not a fan of. We could treat it symptomatically only and shunt the obstructive hydrocephalus supratentorial, but it's not so smart because you really don't drain the cyst, and I think you have local mass effect. The same is true for ETVs or any combination thereof. So I think there are constraints. Endoscopy or open surgery has a relatively high rate of closure and cyst recurrence. VP shunting may not be the right thing. You may have device failure. ETVs have a high reclosure rate and procedural risk and doesn't address the focal local problem of mass effect in the P fossa, and anything that you combine has more morbidity. So what did we do? Well, this again is a patient. She was 31 years old, came into my ER diagnosed with really bad headaches for a few months, but then it turned sour one night. She developed nausea, vomiting, dizziness, vision problems, and cognitive changes. She came into the ER, was adequately diagnosed with obstructive hydrocephalus from a midline arachnoidal cyst. You can see that this lesion sits in the P fossa, is really big and compresses the brainstem, compresses the fourth ventricle. So this one we treated just emergently for obstructive hydrocephalus with an EVD. Opening pressure was 35 and headache immediately resolved. And that gave me the time to think about what do I want to do with this case? And this is what we did first. We obtained further imaging to make sure we do the right thing. This is a typical arachnoidal cyst, but it sits in a bad spot. It sits just below the third ventricle, superior to the cerebellum, sits in the midline and compresses the P fossa and causes a secondary Chiari. So it's a complicated anatomy, and getting there is not so easy. So we thought, should we do this open or minimal invasive? And I felt, a supracerebellar infratentorial approach is maybe not the best because it's very hard to get into someone just at the level of the torcular to drain the cyst. So the idea of internal shunting is quite appealing in this setting. And this is what we did. We decided, why don't we drain the cyst upwards, which sounds counterintuitive, but I actually tell you why this works really well. So you can place a catheter into the cyst, image-guided fixed frame again. We aimed for the middle of the cyst. We want to come in from a post-coronal burr hole going right through this lesion. And we came in through the lateral ventricle, first placed a guide tube into the cyst. We sucked out, I forgot how much, 20 cc's of fluid to shrink the cyst. And then we left a regular Wickham catheter behind, again, connecting the compartment infratentorial to the compartment supratentorial so that the cyst would drain its own content into the lateral ventricle that was now decompressed. After cyst aspiration, there was no longer P fossa compression of the fourth ventricle, so there was adequate outflow. And you can see on the post-op follow-ups, this is the initial picture. After draining this 2 weeks post-operatively, the cyst got significantly smaller and the fourth ventricle opens up. And then 3 months or 18 months later, we had nearly complete resolution of the supracerebellar cyst and re-expansion of the cerebellum, and the patient was asymptomatic. So there are many treatment options available for this condition. So why would we add another one? I think this is the least invasive with the highest quality of life. It's very effective. It is very low risk. And in experienced hands, it's a very effective tool. Last scenario, you all encounter patients that have cavum vergae. Cavum vergae is this odd developmental abnormality that the septum pellucidum doesn't form when the two hemispheres get together during development. It leaves a small space behind. And in some patients, for odd reasons that we don't quite understand, the cavum verge can actually grow like a cyst in the brain, and it can cause obstructive hydrocephalus again because it may occlude the foramen Monroy. So when this lesion is big enough to compress the foramen Monroy, then you get lateral hydrocephalus, bilateral from outflow obstruction, from a cyst sitting in the middle. And here you can think about either placing a catheter from the back coming in, or a catheter like this one coming in from the front that drains the cavum verge after cyst aspiration into the lateral ventricle and allows an internal decompression with equilibration of the pressures, with minimal invasive, less than an hour surgery, and you fixed a problem that is otherwise pretty hard to get to, because dissecting down to this lesion is hard, and bilateral shunts are much more complicated and associated with a higher failure rate. So I want to show you this paper that was published in 1993, which is like 30 years ago, from my old boss in Freiburg in Germany. Christoph Ostertag was really a genius in stereotactic neurosurgery and came up with a lot of smart applications of this technology to solve rather common problems. And I would like all of you to read this paper, which I think is a good encouragement of using a standard technique for a non-standard problem. And we'll show you that this comes with very low complication rates and very high success rate. And that's what we want for our patients. So conclusion, for certain cases, less is more. And I hope that we can talk about this more in the future. Thank you very much for your attention.
Thank you, Professor Kasper. Great lecture. Sometimes when I see new approaches, I ask myself, how didn't I think about this approach? And it's great, and especially how you make connections between certain spaces and you solve your cases. Many of us have different hydrocephalus cases, and we have to deal with that. About normal pressure hydrocephalus, there is a differential diagnosis of Parkinsonism and dementia. Many cases can be met by neurologists who should send the patient to neurosurgeon to decide finally to go for surgery, especially for normal pressure hydrocephalus.
Yeah.
And also by this temporal horn obstruction, as I noticed, I believe that many of your patients with these special circumstances have visual problems, right? Because of the compression of Mayer's loop, right?
Correct.
That's
correct.
Yeah. Okay, thank you. Wonderful presentation, and I will surely think about this surgical strategy in my future cases. Do we have any questions from the audience?
I'd like to ask about the tips and tricks how to keep those catheters in place in case you make a communication between the cyst and the cisterns. How do you avoid the migration of these catheters?
So the trick is that on the pre-surgical films, you want to measure exactly the length of the catheter that you will need. So you need very good imaging, and then you measure the catheter length. I use a soft catheter that is called a Holter ventricular catheter, and make the holes a little bit bigger than the ones I need for the shunt, because I need them both at the tip and then a little bit further up the stream when, you know, the prepontine cistern is connected to the ventricle. And then the end of the catheter will be anchored at the level of the dura with a Rickham catheter, or you could use a Leroy catheter. You could even put in a little vascular clip to make sure the catheter doesn't move, right? So you can, anchor your catheter at the level of the dura when you inserted it, because you don't need the outer part ever again. The whole thing happens on the inside where the cyst drains to the cistern. So if you are in the right space, then this should work out just fine. You need to just be super careful not to lose CSF by at the opening when you make your burr hole, because otherwise your coordinates shift. So you could do this in the OR with intraoperative imaging. Some centers have, you know, fancy imaging, and they can even inject some dye into the catheter and they see whether they connected the cyst. We used to do that in Freiburg. But I think at this point, we've managed to get our precision with a fixed frame. That's why I use a fixed frame for this particular problem. The precision is within the range of 1 millimeter or 2. You're not really missing anything. Whereas I think freehand stereotactic is 5 millimeters off, right? Even in good hands. So I wouldn't do this with a image guided, let's say Vario guide or any time of commercially available freehanded stereotactic catheter placement. I think for this one, you need a guide tube that goes down the barrel in your stereotactic frame to get the stereotactic trajectory perfectly right. If you have a CRW frame, Lexel frame, any of the functional frames available, that's not so complicated.
And you did the same with the case of Kalbenberger catheter. So you anchored it in the dura, or you just made a communication between the Kalbenberger and the ventricle?
No, I leave the Rickham catheter in, either at Coca's point or at the back, and the catheter goes through the Kalbenberger into the lateral ventricle. But you first, on the way in, you use a metal guide tube just for a stereotactic biopsy, same type of guide tube. You suck out the volume from the Kalbenberger, then you place the catheter and go through into the ventricle, right? So you need to decompress the cyst to know that you are in it, and to also make sure that your communication afterwards is opened up. If the cyst is still full, it's not going to drain in an obstructed ventricle, right? So that's the one step you need to think about.
Thank you.
Okay, thank you. Any other questions?
So Casper, thank you very much for a nice lecture. Can you hear? So long time no see. So it looks very, very fine. So for NPH, so do you sometimes do the VA shunt or sometimes the LP shunt? Just let us know, please.
Also good questions, because it's such a common problem. I've completely abandoned lumboperitoneal shunts. I don't like them, but that's a personal opinion that doesn't count. But their failure rate is just astronomical. And it's very difficult also to get the right pressure setting, because your change of positioning makes it very hard for the patient to drain well if they're asleep. And then you need to have a siphoning device. And I recently had a patient who had such a low pressure setting that I just couldn't get the valve right for the longest time. And I think for lumboperitoneal shunts, they also have the problem of, if they ever need an abdominal procedure, if they have an abdominal trauma, even if they're just in a bike accident, they fall down, patients have a much higher risk of making that catheter non-functioning. So that's one thing. VA shunts in the pediatric population has been described, but that's not NPH, right? VA shunts, I would only entertain if you have exhausted all other options and the shunts have been infected multiple times. You can't get a normal catheter back in there. I think VA shunts have a higher risk of thrombosis in the receptacle vessel for sure. They're described as having trouble with shunt nephritis as they age, and they can also cause small emboli. So if I can, I would stay away from a VA shunt or V-pleural shunt, because I think it's a technology that is not good for us. But that's just my personal opinion. Yeah.
Thanks. Thank you very much. Eddie?
Thank you. Okay, then I believe we came to our end of our webinar. If we don't have any other speakers, in front of Association of Neurosurgeons in Bosnia and Herzegovina, I would love to have a special thank to our Professor Kato, our leader of ACNS, who organized this second very successful meeting of Bosnia and Herzegovina, Albania, Kosovo, and Macedonia. Also, I would love to thank to Dr. Raja and Dr. Liu, our co-moderators. And thank you, Professor Kato. You bring us these distinguished, great speakers from Japan, China, USA, and our regional countries. There is also Dr. Ibrahim, the president of Association of Neurosurgeons in Bosnia and Herzegovina, and I would let the word to Professor Ibrahim.
Thank you, Adi. Just few words. That was very nice meeting today. I hope you are all happy that it's be done today. It's early morning in the United States, and it's very late in Japan and China now. However, thank you to be with us this weekend. It's very easy, Adi, to organize this symposium for me also, I think, so for Professor Katov and Lee and you doing very well. So you are the guys who are the machine of these symposiums. And I would like to thank you, Professor Kato, also for covering all these important things and invite to a speaker. And maybe I already can invite you for our next meeting with the day already confirmed, Professor Kato and me, third ACNS Bosnian webinar, which will happen in the September 24. So you are all welcome. Thank you once again.
Well, thank you very much. So just I want to have a word, one word from the Kosovo President, the Alsim, please. Dr. Alsim?
Dr. Arsim, please unmute yourself. We don't hear you.
Please
Pardon?
unmute your mic. Yes, we can hear you.
We hear you now.
Pardon?
We can hear you now. Just proceed.
Yes. Can you say one word?
Thank you again for invitation and for your organization this webinar. I hope we will see together another webinar. As you say, it's September.
Yeah, thanks a lot.
Sure.
So maybe the Albania, the lead one.
Yes, thank you very much for inviting us as a Society of Neurosurgery of Albania. We are delighted to be part of this group of esteemed professionals of neurosurgery all over the world. And we learn a lot from this kind of practical and also research studies that were exposed here. And we are very open with to cooperate in the future in our common field of interest. Thank you very much.
So much. So all the speakers, 10 speakers, are all a top runner of each country. So I think Professor Mukasa and also 2 Chinese and Dr. Yuji Kubota and Abhidasha and also Arion and Yamamoto and Professor Nakatomi and of course the Lidman. So I thank you all the speakers that give us the great knowledge and very nice the surgical videos. So the Casper, please, you should the frequent give us some lectures. Okay, thank you very much. So thank you everybody. So we very successful the webinar today. Thank you very much.
Thank you. Have a good weekend, all of you.
Thank you. Goodbye.
Bye-bye.
Thank you very much.
Bye-bye, Sensei.
Bye.
はい。おやすみなさい。
おやすみなさい。
おやすみなさい。